Okay, good morning, everyone. Thank you all for joining us today. Welcome to the 2026 Empowering Health Conference. This year, we are bridging the future of health by empowering communities through technological preparedness, innovation, and accessibility. My name is Nerese Millette-Williams, Project Coordinator for the University of Maryland Extension, Marylanders Online program, and I have the pleasure of being your MC for today's conference. This event is brought to you by the University of Maryland Extension, Marylanders Online program, and collaboration with our family and consumer sciences partners under Extension. We have a great agenda plan, and we're so glad you're here to be a part of it. Before we continue, again, I want to make sure that everyone is able to have access to our ASL interpreters and our speakers. Can you please show a thumbs up? Perfect. And then I'm about to show my screen, and we want to make sure that you have accessibility to this as well. Can you all see my screen? Just want to make sure. Perfect. For those who are deaf or hard of hearing, I am now going to share my PowerPoint screen. Okay, before we get started, I want to state that all university programs, activities, and facilities are available to all without regard to race, color, sex, gender identity or expression, sexual orientation, marital status, age, national origin, political affiliation, physical or mental disability, religion, protected veteran status, genetic information, personal appearance, or any other legally protected class. Additionally, before our opening remarks, please see the following slide that includes QR codes for our program agenda, our conference survey, and meeting our speakers and planning committee. I will leave it here for a second for you to scan. You can also find these QR codes on our website or your program agenda. We are very excited to get started with our presentations today. We'll begin with a keynote discussion on Maryland's AI policy and health landscape, following a range of topics including AI ethics and its integration across health, workforce, and education. Along the way, we'll explore emerging technology trends, share strategies for reaching diverse populations, and highlight presentations from undergraduate students in the School of Public Health on the intersection of local and global health systems. We'll wrap up with a brief discussion about the University of Maryland Extension's key contributions to advancing health technology, including current initiatives and research. As we move through today's conference, please feel free to ask questions using the chat or Q&A function and engage with speakers and presentations using the reaction features on Zoom. ASL interpreters will also be pinned at the top of the screen throughout the conference for accessibility support. You are also welcome to turn on closed captions, and Zoom allows captions to be translated into different languages. Additionally, if you are able and if you are open to it, we encourage everyone to turn on their cameras and ensure that your display name matches the name you use to register. Before we begin, I'd like to note that all presentations are the property of the respective speakers. If you're interested in receiving copies of the slides, that will be at the discretion of each presenter, as UMD does not retain ownership of the materials. You'll also see a disclaimer at the bottom of each slide indicating whether a session is being recorded and intended for public viewing. If a session is not marked for recording, it will not be included in any video posted on YouTube. So to begin our program, please join me in welcoming our keynote speaker, Tasha Cornish, who will be presenting on the strategic intersection of AI policy and clinical care in Maryland. Tasha Cornish serves as the Executive Director of the Cybersecurity Association, Inc., and is a prominent voice in Maryland's technological governance and workforce development. With a Master of Science in Public Health from Johns Hopkins University and a background in neuroscience, Tasha occupies a unique niche at the intersection of human wellness and technical resilience. She is a driving force behind Maryland's efforts to ensure that emerging technologies like AI are deployed equitably, securely, and ethically, advising the Maryland General Assembly on critical health cybersecurity standards and AI implementation frameworks. Please join me in welcoming Tasha Cornish.
Good morning, everyone. Send this request to share my screen. Oh, there we go. Okay. All right. Here, moving all these things around. I'm going to go into full view. Perfect. So thank you so much for the introduction and the opportunity to be here today. Excuse me. This is a topic that I care about personally, and the association is very interested in, as it's a key critical infrastructure and it's key to all of our daily well-being. So to start off, I just want to ground us in two really distinct approaches that you'll see within the healthcare system, that really the necessity of has really just increased with the integration of AI. So we have our board priorities, right? We have pressures from hospital boards, from administrators to really focus on risk mitigation and ROI. Many AI tools have now been implemented into financial operations, clinical operations, to make those smoother and reduce any excess spending. In 2026, healthcare executives must really treat AI governance also as a fiduciary duty to prevent catastrophic liability from biased algorithms, as well as data privacy concerns. And then you have the server room realities, and we won't focus too much on that conversation today. You could, imagine I go into this far deeper with other audiences, but really the monitoring our publication of known vulnerabilities and exposures in lateral movement. That's just, a bad actor gets into one computer and then can move across the network to what they really want to access. And as you may have heard, AI really expands the exposure and the attack surface within the healthcare system. And it really demands other kind of emerging tech, quantum resistant encryption, and real time detection to protect our data and our systems. Exciting news in Maryland. Maryland really is among the most innovative states when it comes to AI policy. So last year, the Maryland Department of Information Technology established the 2025 AI Enablement Strategy. And this roadmap positions Maryland, as I said, as a national leader because a lot of states aren't quite there yet. And what's really exciting about this strategy is it does have a lot of information on governance capability maturity. This has been a real blind spot for a lot of leaders. So this is great that it helps provide some guidance so we don't have to figure it all out on our own. It also provides some authoritative data foundations. We know in AI, the data that's being used to train models and to create algorithms is really it's going to be a challenge. So providing these data foundations is really helpful, and as well as sector specific safety guidelines. We know that AI will impact the sectors in slightly different ways. If you're a utilities leader, you have to think a little differently than a healthcare leader about how AI can enable and potentially harm your operations. So really exciting to see that they noted the sector specific safety guidelines here. Additionally, I didn't include it because it's not really relevant to this presentation, but in 2025, they also created a work group on cybersecurity and healthcare specifically, which again really affects those talks about those challenges, especially in rural and small healthcare systems. Just I wanted to highlight one of the bills that was also passed this year. And I think this also reflects just what we see in the media is a lot of concerns about the use of AI in behavioral health, how folks use chatbots as their therapist. And so in order to ensure that that doesn't happen in the professional market, this 2026 policy prohibits AI from replacing human providers in the clinical assessment or diagnosis. So, really important to, again, have those guardrails as we're moving forward with innovation in healthcare. The human in the loop mandate, I know that folks will go into this a little bit deeper in a later presentation, but I think it's really, really important to remember this when we're talking about clinical accountability. You always need that independent review that any AI generated data, presentations, diagnoses, et cetera, claim details even are reflective of reality. I'm sure we all have experience in playing around with AI, and AI comes up with some very outlandish topics. So we definitely want to make sure in the clinical setting that it has that independent review. Confidentiality agreements, also huge. There's always been a lot of data governance and custody within the healthcare system. And so want to make sure that it's never used to train global AI models. Transparency notices, patients should always be informed before your clinician is going to use AI that they're going to use it. And honestly, I think you should also be allowed to opt out of it if you don't want it. I think there's many advantages, of course. Physicians will share that it helps them actually be more engaged with the patient, right? And helps to create better care plans after because it can just summarize exactly what was spoken about. But, it is a patient's right to know when AI is being used. And again, these ethical guardrails that, therapeutic communication, especially, is a really just high visibility topic. Want to make sure that it's not generated solely by AI. I also just want to, uh, hit home what we talk about a lot. Really, cyber safety is patient safety. Um, and that patient provider relationship is really special and should be, treated as such. And, keeping our data protected, keeping our systems up and running to ensure clinical care, it really should be seen as a patient safety issue. And I think a lot of healthcare leaders really understand that now. I wanted to dive a little bit deeper into the sub-cabinet framework. So this is, again, activated now in Maryland. So it is overseen by the Do It Secretary and really make sure that, state agencies across the board are collaborating. And instead of, opportunistic pilots, we're really going to structured evaluation-based AI adoption, which is again, really key in healthcare, but we're seeing across all industries, right? We've seen a lot of investment in AI, and we really need to move now to the evaluation-based AI adoption and figure out which of these is actually paying off. And lastly, it does provide a framework for training the 2026 Maryland workforce to use AI, not as a replacement, but a tool that will augment your work. And I think that this, again, providing that framework to healthcare overall is helpful so that each hospital system and healthcare system isn't bringing this out by themselves. I also just wanted to add a couple of these strategic guardrails that we're seeing hospitals implement and will be further adopted. Again, I guess the transparency to really make sure that consumer trust and liability protection is there. Really want to make sure that we do quarterly bias audits for diagnostic tools because we don't, again, it falls into regulatory compliance. Safety, ensure that all of these have the human in the loop. And cybersecurity, we sometimes like to call it human on the loop because really you want to have visibility into the entire system, not just, your little place within the circle. And then lastly, just validate these algorithms, make sure they are peer reviewed and evaluated regularly. Before I wrap up, I really want to talk about how AI can be used for equity by design. I think sometimes when we talk about technological advances, we get really excited that, rural settings or settings in less developed countries are really going to be able to leapfrog and be on par with what we think of as healthcare in, the developed world in the US and such. But AI can really be harnessed to be more than that. I think a lot of parts of the healthcare system are universally understood or thought of as broken. And so we can use AI to really create a new healthcare system, leverage AI, I should say, to help create a healthcare system that really does provide access to everybody, and really that accessibility is the foundation of trust. And if we don't have algorithmic bias, we can really help with reducing the health disparities, we see across the state. So I just want to close with this. Throughout the day, you're going to see a lot of presentations on workforce and innovation and ethics and how we're going to implement all of this. So hopefully this conversation provided you with an overview of the guardrails many are implementing. And really, again, the security asset is not the code we write, but the trust we maintain through rigorous governance and clinical accountability. So thank you very much for your time this morning. I greatly appreciated learning more about the agenda and the speakers, and I know you're in store for a wonderful day.
Awesome. Yes, thank you so much, Tasha. Please feel free to add your reactions and applause. Thank you for being here today and for sharing such thoughtful and informative insights. We really appreciate you taking the time to be here for our conference today. And please note that you all can find Tasha's information on the Marylanders Online website, on your program agenda, and you can also scan the QR code listed here on the PowerPoint presentation. If you have any questions, please feel free to use the Q&A function or ask questions in the chat, or if you raise your hand, we will be able to unmute you. Next for our agenda, we are pleased to begin with our first presentation on securing the future of AI governance, cyber readiness, and institutional accountability. Isaias Tesfalidet is a legal and policy expert with over 18 years of experience in international law, digital transformation, and public sector innovation. He currently serves as project director of Marylanders Online at the University of Maryland Extension, where he leads statewide efforts to expand digital literacy and access in underserved communities. A graduate of Yale Law School, his work focuses on how institutions implement technology while ensuring accountability, managing risk, and advancing equitable access. He has advised governments, international organizations, and private sector clients on AI governance, data protection, and migration policy, and other global institutions. Let's give a warm welcome to Isaias Tesfalidet.
Thank you, Neris. Good morning, everyone. If you can enable my video.
You should have access, Isaias.
All right. Still says cannot start the video. All right, while you do that, so thank you everyone for joining us, and thank you, Tasha, for that excellent presentation. And it's an excellent segue for me as well to delve into AI governance, cyber readiness, and institutional accountability. I'll start sharing my slide. Hopefully you can see my slide. So the title for our workshop, and hopefully this will be a workshop instead of a lecture, we'll try to make it as interactive as possible. Securing the future of health, AI governance, cyber readiness, and institutional accountability. As Tasha showed us, these are interconnected issues and really important discussions to have both at the institutional clinic health system level, as well as at the state, regional, and national as well as global levels. Before we start, as members of the University of Maryland Extension, we receive funding from the state, federal, and local governments, and we are required by law to ensure that university programs, activities, and facilities are available to all without regard to race, color, sex, gender identity or expression, sexual orientation, marital status, age, national origin, political affiliation, physical or mental disability, religion, protected veteran status, genetic information, personal appearance, or any other legally protected class. Having said that, I will briefly describe what the University of Maryland Extension does and what its main goals and activities are, and how the Marylanders Online Digital Literacy and Digital Navigation Program fits. The University of Maryland Extension has offices in all Maryland jurisdictions, the 23 counties plus Baltimore City. The University of Maryland Extension is not a degree granting part of the University of Maryland system. Instead, we try to translate cutting edge science and knowledge into use by ordinary folks. So we work with community members at the hyperlocal level, community-based organizations, local government, nonprofits, businesses. And the Marylanders Online Digital Literacy Project is funded through the American Rescue Plan Act, state and local fiscal recovery funds. And as Neris mentioned, we aim to increase broadband adoption across the state of Maryland by providing digital skills training, digital navigation, really starting from foundational skills to fluency and applied skills. Similar to other University of Maryland Extension programs, we operate statewide. We collaborate with the Office of Statewide Broadband, the Department of Labor, local governments, as well as businesses and community-based organizations. With that background, I will proceed to a few disclaimers and news. My background is in law, but I want to make sure that this presentation is for educational purposes only. It does not constitute legal advice. If anyone, either individually or as an organization, are considering deploying AI or other tools, they need to consult their own organization's legal, clinical, privacy, and security teams before changing policies or deploying AI. We will discuss some cases, and in my presentation, I do not intend to litigate the facts. We'll use them as educational background. The cases are before courts or have already been decided, but I do not take any position one way or the other. With that disclaimer, the learning objectives for us for this session, this is not going to be a really technical deep dive. It's perhaps aimed as a practical leadership conversation. We're going to ask ourselves, when AI tools, either generative AI or agentic AI, are deployed in our healthcare systems, in our clinical practice, in some of the settings that Tasha mentioned before my presentation, we need to ask ourselves, who decides from early adoption to monitoring and when to stop when a tool is counterproductive or harmful? Who owns the risk? There may be risks of physical harm, mental harm, administrative, financial. So who owns the risk? And eventually, how do we stay safe? And the goal for this presentation is that we will leave with a set of cautions and a list of checklists that we can take to our organizations to continue the discussion and ensure that AI deployment is done in a responsible and safe manner. Having said that, we'll cover how do we assess readiness? Tasha mentioned maturity. How do you check your organization is ready to integrate AI tools? What are the governance levels? Okay. How do you distinguish risk tiers and define exactly when human oversight is clinically essential? This is the man in the loop or human in the loop or human on the loop discussion. And once you have identified the risk and categorized them by levels of severity, how do you mitigate the risks? It can be legal, ethical, and cybersecurity vulnerabilities. Importantly, also risks to the patient and by extension to community and social outcomes of health. And then how do you define liability? How do you establish data protection, bias mitigation, and clear compliance considerations? Some of you may have seen some of the lawsuits against OpenAI, Meta, and other technology companies. And in Florida recently, towards the end of April, the Attorney General expanded the investigation that started out as a civil matter into potentially criminal liability because an individual used ChatGPT to plan a mass shooting in Florida State University. So who is accountable? Is it the institution or is it the human? So those discussions are really coming to the forefront. And finally, we'll apply some frameworks. We'll discuss some standards. As I mentioned, it's not going to be a deep legal technical discussion, but at least we get to ask the really relevant questions and take some guidelines with us for to our organizations. Now, the objectives are part of a strategic pillar of institutional accountability, as we'll see. I want to pause here, just pose a question, which we'll come back to towards the end. And feel free to send your questions, your responses in the chat. So we already know AI is already making decisions in healthcare. It's contributing to documentation, scheduling, messaging, triage, and clinical support. So I want to ask everyone who has any experience of their healthcare provider using AI tools. I had a recent experience when I went for an annual checkup. My provider was using a mobile device, which was transcribing some of the conversations we had. So that comes to consent, right? Making transparent that AI tools are being used. How many of us have experience with that? And did we receive either verbal or written information to express our consent? Now, while we're thinking about that question, when something goes wrong, is it the clinician? Would it be the health system? Would it be the vendor? Because those tools are not most of the time made in-house by the healthcare system. Or is it the board of directors, the legal executive leadership? So this is not just a technology question, as we'll see in some of the examples we'll discuss later. It's also a governance and authority and decision-making question. Now, we need to reframe the problem. As I mentioned, when you introduce new technology, specifically AI, whether generative AI for scheduling, documentation, or agentic AI, as we will see, that can make recommendations and advice, there is a distribution of workflows. And sometimes the authority to make the decision is not really visible. And then responsibility becomes diffuse, it's fragmented, or sometimes merely assumed. And there is accountability gap when Usually it's discovered when some harm has already occurred or something tragic happens, either a mass shooting or that's in a non-healthcare setting, but some harm is done to the patient. Now, governance really is not optional. It's already happening, but the governance may be happening informally or poorly. So to ground our discussion, I'll go through some core concepts. What does governance mean? What does readiness mean? And what does accountability mean in practice? Now, AI governance, in summary, means who has the authority to approve, monitor, or shut down AI systems within the institution. I mentioned the example of a provider using an AI-enabled transcription tool. If it starts to make errors in accurately transcribing, who decides it needs to stop or fix it, and who determines or who at least monitors the errors? And then what does cyber readiness mean? It's whether the systems are secure, resilient, and safe under real-world clinical conditions. If it fails, will it still be failing safely for the patient? Third, institutional accountability. As I mentioned, when harm occurs, who answers? Would it be a technical and how do you trace the technical and clinical decisions? Now, the role of AI is rapidly evolving, and the kinds of tools are also evolving at a really rapid pace. When the shift from general generative AI to agentic AI shifts, it's also a shift in authority, risk, and decision liability. In summary, generative AI usually is used to produce content, support human decision making. It acts as an advisor. It's not a decision maker in itself. It's an augmentation. It can help with automating clinical notes, patient summaries, communicating either through SMS messages or other tools. And then in operations, in workflow, either administrative or financial, it can help with scheduling, billing optimization. The real risk and complexity comes in agentic AI when, as advertised by the companies that produce this, it plans and acts and executes tasks autonomously. In practical terms, it's acting as a decision actor. Now, if it makes a clinical recommendation, direct treatment, or action suggestions, if it influences care pathways and priorities, if it triggers operational and administrative workflows that result in some kind of harm. We'll look at some cases, and I will try to pause and give a chance for folks to ask or share experiences. One of the cases that happened is an AI tool, and Predict was used to determine the length of care in a facility. Now, in this case, the tool is alleged to predict how long a person should need post-acute care. Now, the risk is when the prediction becomes the default setting, and then a clinician has to do an uphill battle to change that decision. Now, if staff must justify the exceptions, the model is effectively managing the workflow. Now, you can ask the question, who is actually practicing medicine? If the clinician or the doctor is merely taking the suggestions, now you can see where the authority shifts from the human to the AI tools. Now the lawsuit is ongoing. there is a huge discovery, and the court ordered that a lot of documentation needs to be produced. Another case with Humana is automated claims processing. Now there is high volume of approvals and denials. It's really not easy for a human to keep up. With that level of volume of automation, and the human in the loop becomes a rubber stamp practically. Here, the allegation is that the claims decisions were automated at scale with limited meaningful human review. Now, if the human has mere seconds or just minutes, if you go to your healthcare provider, you'll notice, right? Sometimes they have to rush from one to the other. Now, does the reviewer have the authority to say no without penalty? If you're in a large healthcare system, an AI tool says we can recommend a test or a lab or some form of diagnosis, but the AI tool says that's not needed. Now, sometimes the clinician may fear retaliation. And if that's the case, where we need to think, where does human judgment meaningfully enter the system? Another case is with Rite Aid. It uses facial recognition that flags customers, and employees regularly act on system alerts. In this case, the pattern becomes sort of universal. When a system flags something, the humans tend to treat it as a truth. Now, what happens when the system is wrong? As we asked earlier, who owns the incident response, appeals process, and remediation? I'll move quickly through these cases. There are other examples. The EPIC sepsis model, this is a tool that was designed to detect sepsis, and it missed cases and generated false alert. So this is a case of unmonitored AI governed by a vendor that becomes a clinical risk. Another one was Optum. It used healthcare costs as a proxy for health needs. Now it leads to bias. As Tasha mentioned earlier, there is an equity component, ethical component. Bias is not just a technical glitch in this, it's a governance failure. Similar in the UK, DeepMind and the Royal Free, there was inappropriate patient data sharing without proper notification. This is the cyber readiness component. Now, the common thread we see is AI output is treated as authoritative without meaningful validation or oversight. Now, an example, so I'm not advertising for this, but an example where the AI tool was deployed in a responsible manner is, one, there is a narrow use case. It's not deployed at scale. Second, there is a defined workflow. Third, there are measurable outcomes. And fourth, there is clear authority. So the key takeaway from this is, if there is a narrow, measurable, and we assign a clear owner of the risk and the liability, then you can expand only when the evidence supports it. Now, there is always pressure of, for-profit entities trying to move quickly and innovate faster than their competition. Now, having discussed this, what do we do with risk and readiness? We'll be able to share this slide deck. I will not go through each one of those, but the key takeaway here is AI risk is multi-layered. When failure happens somewhere, either at the technical, clinical, or operational, it cascades upward, and then a model error ends up becoming an institutional liability. Now, for example, you can see there is legal and regulatory. There there's civil rights and equity, reputational risk. Some of the examples of failure are the model drift. There is data poisoning. Whatever data the model is trained on may have been poisoned. Now, if you want to measure readiness, you have to be able to answer the following questions: governance, cyber readiness, clinical, operational, and accountability. In short, safe AI or responsible AI is not just built, it's governed. So if we are not able to answer these questions, that would mean we're not ready for deployment. We've discussed this, but just to summarize, if all AI failures would be broken down into governance, readiness, and accountability, or a combination of those. Just for awareness purposes, there are global standards, national standards that govern AI readiness and how to deploy AI responsibly. So the NIST guidelines, this is the voluntary gold standard for trustworthy AI deployment in the US, has three main components for governance under institutional culture and accountability. First, you have to establish the context, identify the risk, and analyze potential impacts. Second, you have to measure, you have to assess, analyze, and quantify AI risks through rigorous metrics. And this has to be documented. Finally, once it's deployed, you have to prioritize and respond to risk based on institutional tolerance, how resilient your systems are. And it obviously in compliance to applicable laws and regulations and contractual obligations. Another example is the international standard for establishing an AI management system. In terms of compliance, there is HIPAA and privacy, and then you have FDA and ONC oversight. So the governance challenge is there is security rules that must evolve to address data poisoning and model inversion attacks. Some state laws, Tasha mentioned earlier, the Maryland AI enablement strategy. There's an AI working group and the new House bill that deals with AI in behavioral health. Some other states in Colorado is the first major US law requiring reasonable care to avoid algorithmic discrimination and mandatory impact assessments for high-risk AI. Similarly, in California, we have regulations regarding automated decision-making technology, and it grants output rights and profiling transparency. This is part of the ACA section 1557, deals with algorithmic bias and accountability gap. Some litigation that's either ongoing or has been resolved. We discussed the estate of Loken, the United Healthcare. It's a class action alleging AI was used to cut off post-acute care prematurely, overriding clinical necessity and doctor judgment. This case is still ongoing, but the key is the court allowed for class action and discovery of all the documentation that resulted in decision at each step of the AI deployment. And we also discussed the Humana case. This is litigation over AI-driven claims processing that resulted allegedly in automated medical necessity denials without human review. So litigation is already happening. Liability is already featuring prominently, and it's defining the boundaries of AI use. really faster than policy or legislation can catch up. Now, we discussed this, but to summarize institutional requirements for AI oversight, there has to be a named authority. The decisions have to be traceable. The systems have to be auditable. And there have to be clear escalation pathways and enforceable vendor accountability. So a question for all of us is, if we have an AI tool deployed in our systems and something goes wrong, will our organization be able to explain where the error happened? Finally, we'll send this in the email after the presentation, the accountability checklist. These are some questions that leaders must answer before AI is introduced. Now, first, is there a complete inventory of AI? Do we know which systems incorporate AI tools and what kind of AI? Is it agentic or generative or other forms of AI? Is there evidence of effectiveness? So are we adopting the tools because they enhance patient care, or is it, so it has to be validated by data? Have we considered bias and equity? Is there meaningful human oversight? Are the systems monitored to track performance, check model drift, and then trace clinical outcomes as well? Now, in terms of patient and clinician, are they fully informed? Is there incident response plan when something goes wrong? Do the contract protect your interests? For example, audit rights, data rights, performance obligations, and exit rights. In terms of compliance, are we meeting legal obligations? And do we know when to sunset, when to shut down the systems? Finally, want to highlight that the core of safe AI adoption is not simply efficiency. It's not, and the question is no longer whether to adopt AI or not. It's whether institutions can withstand its failure. When AI fails, will it fail safely for the patient, for the organizations, and for the society at large? With that, I will pause for any questions, and I'd like to encourage people if they have any questions or if they want to share experiences.
Hi, everyone. Please feel free to use the chat or the Q&A function in order to ask questions, or you can also raise your hand and we will be able to unmute you.
Now, there are a few questions in the chat. Maybe we can start with those as people prepare. Someone says, I think the human technician needs to oversee ultimately. Well, that's one level really, right? But the clinician may not have sufficient authority to make decisions. And the institutional culture is also really important. Whether the clinicians have the training, the awareness, and the confidence to report issues. But that's now the human clinician is practically the end user, right? But when AI is deployed, the decision is coming from a different source. It might be the executive, it might be the technical team or the legal team. when you receive some tools in your organization, you will see, right, something is provisioned to you. But does the organization have meaningful feedback process to alert about potential harm? And does it take it seriously enough to rectify? Another question is, doesn't AI not only collect information from the web or other online resources, but is also response based on our responses? I think the individual needs to remain accountable. Some AI or the AI we were talking about doesn't work without human engagement first, if I'm not mistaken. That's an important perspective. So the way the AI models are trained, they have a baseline data. It might be scraped from online sources, or some data may have been ingested. For example, we recently launched an AI chatbot for the Marylanders online website. We made sure it was restricted to the data we had internally collected. It doesn't have access to the open web. But we vetted a few websites from the university and other trusted partners, and we specified the scope of the information it can ingest from. But this comment is also correct. The AI models also continuously learn from the inputs. When you use a ChatGPT or Gemini and you're interacting with it, that is also contributing to its. The key component, the individual needs to remain accountable. This is individual awareness and individual accountability. But in some instances, the individual doesn't really have a choice. In some of the cases we saw, if AI tools are used to make decisions about the length of care or type of care, the individual is really at the receiving end. Another question is, are there any special legislation preparation devoted exclusively to the AI healthcare? There are some in progress, some already we discussed. We will share the slide with you. In Maryland, Tasha mentioned the legislation to prohibit AI replacing humans in behavioral healthcare. Can you discuss feedback process and the organization would have? So these are really, someone is asking, how do you explain situations like the one in Florida when AI assists dangerous motives or activities? If for folks who are not familiar, someone used ChatGPT to get recommendations on weapon effectiveness, location, and time of day when there will be more people. So that's ongoing. Those are the questions I see so far. If anyone else, Neris, are we on time?
Yes, you have about 4 minutes. I do see a couple additional questions that I'll go ahead and ask you from the chat. Can AI correct a poor institutional culture? And this is from Jean Davis.
Well, potentially, but if an organization has a really, broadly speaking, bad culture, whatever tools you bring may not improve that. But potentially AI, for example, if the organization has to adopt a suboptimal procedure because they don't have the resources, if they augment their resources with AI, they may be able to, because sometimes good practices cost money, right? If you have to comply with all regulations and laws, AI may be able to bridge that and bring the organization to compliance. Next.
Next question, how do you explain situations like the one in Florida when AI assists dangerous motives and activities? Is it due to loosely implemented ethics from these AI creators?
Well, yeah, I mentioned that earlier. So what's going on now is the Florida Attorney General expanded the investigation to include potential criminal liability of either OpenAI or the executives and leaders at OpenAI, and they're requesting extensive documentation. In this case, OpenAI voluntarily shared the chat logs of the individual who did the shooting at the university in Florida. I'm not sure how it will end, but that's a really ongoing and difficult question to answer. Eventually, it might be a case of product liability or corporate liability. Yeah.
All right, everyone, it is now 11:15 a.m., so we will go ahead and proceed with our conference agenda. Thanks again for joining us, and we're excited to continue the conversation with a panel of incredible individuals who will be discussing universal innovation, advancing AI without leaving communities behind. Our panel moderator is Terry Mumm, Digital Navigator Program Manager at the University of Maryland Extension. Terry holds over 21 years of experience in community program management and has led statewide and national efforts to advance digital equity and close the digital divide. Her work focuses on expanding access to affordable broadband devices and digital skills for underserved communities. Our panel brings together an outstanding group of experts. Dan Doggett is the IT Accessibility Program Specialist with the Maryland Department of Disabilities. He supports state agencies with digital accessibility training, compliance with the Americans with Disabilities Act, and auditing web and IT systems. He is a Section 508 trusted tester with a background in education and e-learning development. Dr. Jessica Stansbury is Director of Teaching and Learning Excellence at the University of Baltimore and founding director of CALE, Center for AI-Driven Learning and Community Engagement Innovation. A national voice on generative AI in education, she brings experience as a former psychology faculty member and addiction therapist, and is widely recognized for her work on AI, learning, and human behavior. Dr. Deborah Wilson is an AI consultant with 20 plus years of healthcare experience focused on improving operations, engagement, and outcomes. She specializes in making AI practical and accessible, helping organizations and communities confidently adopt real-world AI tools. She also provides consulting and training through AI Healthcare Consulting. Dennis Tran is a storyteller, speaker, and inclusion strategist based in Los Angeles with a background in public health, media, digital health, and nonprofit leadership. Dennis bridges lived experience with systems change to advance diversity, disability justice, and mental health advocacy. And our last panelist, Mustafa Rafat, is a PhD candidate in social work at Washington University in St. Louis and a McDonald Scholar. His research explores forced displacement, disability, structural inequities, and the social determinants of health. He will join the University of Nebraska Omaha as an assistant professor in fall 2026. Thank you, everyone, for joining us, and the floor is yours, Terry.
Thanks so much, Nerys. What a great group we have. And also, you're doing a fantastic job leading us today. So over the next 45 minutes, we're going to dig into one of the most important conversations happening right now. How do we make sure that AI and emerging technologies actually work for everyone, including those who are often left behind? So today we're going to start with 3 short presentations from 3 of our panelists. They're going to be like 5 to 8 minutes each, and then we will have some key questions and some time for, hopefully, time for discussion after. We got a lot packed in here, so let's dig in. First up is Dan Doggett. I'd like to let him take the floor.
Thank you, Terry. Can you all see my screen?
Hmm?
Okay, great. So hello, everyone. Today, I wanted to briefly talk about the intersection between AI and digital accessibility, and also discuss some strategies to ensure that our digital content and services remain inclusive and equitable. So we are increasingly using tools like ChatGPT or Claude to build our web content, whether it's websites, apps, or various other digital content. And currently, it feels like a massive leap forward in productivity. However, this efficiency creates a specific technical risk. AI models frequently generate code that ignores accessibility standards. So if we don't actively audit this output, we are creating digital products that are fundamentally broken for millions of users with disabilities. So to understand the risk, we need to understand specifically how AI works. So when you ask ChatGPT a question, it's not actually thinking about the answer. Instead, it's looking for patterns in the existing web and provides the most likely answer based on that data set. So it's essentially a super-powered version of the autocomplete on your phone when you're texting. So what's the problem with this? Well, the problem is, unfortunately, the internet is currently broken for most people with disabilities. A recent audit of the top 1 million homepages by WebAIM found that nearly 96% contain detectable accessibility barriers. Because AI models learn from this flawed data, they default to these broken patterns. So when we ask AI to build something for us, it doesn't provide the most accessible version. It provides the most common version. So we're now entering an era of vibe coding, where complex applications are built using nothing but natural language and vibes. So this is super empowering for the general user, but it creates a knowledge gap. Without a foundation of inclusive design, creators can't audit what the AI produces. They won't know how to fix a product that is fundamentally broken for people with disabilities. So to use AI effectively, we must first understand the humans we're building it for. And the solution here is to be intentional with our prompting. We need to move away from broad descriptions and move towards specific technical requirements. Accessibility must be defined as a core constraint of the prompt from the very beginning. So let's talk about some of the things that we can include in our prompts to make sure that we're being inclusive from the very beginning. The first thing that we need to focus on is keyboard access. So many users do not use a mouse, either due to visual or motor impairments. When you build your interactive components, you need to explicitly tell the AI to ensure that all links and buttons are keyboard selectable and that they have visible focus. Second is screen reader support. So users with visual impairments often rely on screen readers, which is software that reads the code out of a page out loud. So to ensure that the AI builds a page that makes sense to screen readers, we need to prompt for semantic HTML. So for non-technical folks, think of semantic HTML as a digital roadmap. It uses specific tags that tell the computer exactly what each part of the page is, not just what it looks like. So to fix this, your prompt must be specific. Include in your prompt to use semantic HTML tags and provide clear text descriptions for every icon so that a screen reader can actively describe its function. And third, we need to think about visual clarity. For users with low vision, we need high contrast between its text and its background. So make sure to include in your prompt to ensure high text contrast and make sure that color is not the only way to convey information. So even with the best prompts, AI will still occasionally miss the mark. So this is why all development should include human testing and verification. You don't need to be an expert developer to verify the AI's work. You just need to perform some basic checks. So there are two simple methods you can do when checking your work. First is the no mouse check. Put your mouse aside and try to navigate through your site or application using just the tab and enter keys. If you get stuck or get lost trying to figure out what element is in focus, the site is not keyboard accessible. Next, I recommend using free automated accessibility testing tools like Wave or Axe DevTools. These are browser extensions that act like spell checkers for accessibility. And so they'll highlight things like when AI misses a label or uses colors that have low contrast. So AI might be removing some of the burden of learning to develop, but it doesn't remove the responsibility to make our content inclusive. By using intentional prompts and performing a few simple human checks, we can build a digital world that is accessible for everyone. Thank you.
Thanks, Dan. It's a very important framing for everything we're discussing today. Appreciate it. Next, we'll hear from Dr. Jessica Stansberry. Jessica is going to talk about AI companions and how they're impacting mental health. Jessica?
Okay, can you see just the presentation? Okay, great. Thank you. Hi, everyone. So my name is Dr. Jessica Stansberry. I am here today to talk about AI and mental health. This is near and dear to me as someone who was in the substance abuse field for over a decade. And today, I really want to invite us to think differently about AI and mental health. So not as a technological innovation, but as a community issue. So as AI tools become increasingly integrated into healthcare, therapy, and emotional support systems, we need to start asking questions such as, who is this technology really designed for? And is it being designed to strengthen human care, increase equity, and expand access, or could it unintentionally deepen inequities and disparities, reduce trust, and replace our human connections? So I take 4 guiding principles on this journey with us: people, equity, trust, and understanding. So today my focus is specifically on AI companions, and not on the AI companions that we would necessarily see in a clinical setting, but the AI companions that are being marketed outside of clinical settings. So the ones that I say we're really exposed to, and that our youth and our young adults are being exposed to. And if you aren't familiar with AI companions, so AI companions are basically, there's a multitude of different apps out there, and you can essentially create your own companion, whether that is a romantic partner, whether that is a friend, whether it is a mentor. You can change, you can create their features, and you can even talk to them on the phone. And their voices actually sound pretty realistic. So what is driving these AI companions? Well, the rapid growth is an emerging reality. And by 2035, we're going to see a projected $552 billion spent in this market. If you do a Google search on AI companions, you will see the growing amount of different companies that are doing this. Why is this happening? Well, first, emotional demand is rising. People are increasingly seeking AI not just for productivity, but for emotional support and mental wellness. Second, regulatory systems are beginning to pay closer attention, especially as vulnerable populations engage with these technologies. And third, AI companions are becoming culturally normalized. They're appearing in daily wellness practices, social interactions, and even in intimate spaces. So they're moving into our everyday life, which makes public understanding and ethical design more urgent than ever. So there's this tension that happens with AI and these AI companions. At best, AI can serve as a bridge. It can expand access, it can reduce our stigma, it can offer triage, and it can support our underserved communities. However, it can also act as a mirror or an echo chamber because it actually reflects and reinforces our beliefs, our behaviors, our emotional patterns. Remember, it's not a person on the other side, it is a machine. So without those intentional safeguards, AI risks becoming a replacement. It can substitute for human care, weaken our empathy, and encourage dependency. So the critical question you have to ask yourself is, does AI strengthen our human systems, or is it quietly starting to replace them? And the answer really depends not on the technology itself, which is advancing and advancing rapidly, but on design and governance and community-centered implementation. I firmly believe, Callie firmly believes, that AI should amplify our human potential and not diminish our human connection. So how do we move forward? We need to get from access to agency. This framework begins with awareness. So first, we must recognize we need education. Then we need to understand what the benefits and the risk are. We need to critically engage and ask questions. And then we need to provide support. How do we do that? Through the big three: preparation, education, and agency. So in preparation, people are our foundation. Technology is just a tool. So we need to make sure that our community and those interacting with these different types of AI companions out there are educated and understand. From there, we need to empower people, not create a sense of fear. And then we need to empower them to co-create with us. So we need to understand and build a future of trust and technology that uplifts our humanity. Thank you.
Oops, sorry. Thank you, Dr. Stansbury. We're going to move on to Deborah Wilson.
So, as I was saying, the reality is technology launches don't equate to real success. I've worked with healthcare leadership teams rolling out new AI digital tools. Yes, it looked like success. New systems were launched, features were working, leadership was excited, but behind the scenes, the staff was overwhelmed. Not because they weren't capable, but because no one designed the experience for how they actually work. I remember one care manager saying, "This tool might be great, but I don't have time to figure it out while I have patients waiting." Right there, that's the moment things break. Not at the technology level, but at the human level. When we look at what's actually blocking AI adoption, it's people with real fear, fatigue, and skepticism in using these AI tools. The shift comes when we stop asking, what can AI do? And start asking, who will struggle to use it? What are their fears, their resistance to change? These questions change everything. It puts people first. Let me share 4 practical ways to close the AI gap. 1, first-time user experience. Most tools are designed for people who already understand them, but real impact happens when you design for the person who's never seen it before. For example, a healthcare organization rolls out an AI-powered patient portal. Instead of assuming people will explore it, the healthcare organization creates a Start Here button, a 60-second walkthrough video, and even better, they use ChatGPT to generate step-by-step instructions at a 5th grade reading level and create versions in multiple languages. Now, the tool doesn't just exist, it welcomes people in. 2, design for real life. Here's a mistake I see all the time. We design AI tools as if everyone has high-speed internet, a laptop, and time to sit and learn something new. That's not reality. For example, a caregiver in a rural area is trying to use a digital health tool with spotty Wi-Fi, only has a phone, and is managing medications, appointments, and stress. So what works? Mobile-first design, offline-friendly features, and short instructions, not long PDFs. That changes how you build AI. 3, clarity over complexity. AI tools are powerful, but they often sound like they were built for engineers and not everyday people. For example, AI, instead of saying AI leverages predictive analytics to optimize care pathways, no, say this tool helps you spot patients who may need extra support before things get worse. And here's where AI really becomes your advantage. In using a tool like ChatGPT, Claude, or Gemini, your teams can turn technical instructions into plain language, create a quick reference guide, and generate scripts that staff can actually use with their patients. You're making AI usable for everyday people. 4, human backup. Listen, not everything needs to be automated. And honestly, That's a good thing. For example, an older adult tries to use an AI driven scheduling system and gets stuck. Instead of hitting a dead end, they see, need help? Call us to speak to a real person. That's where trust is built. Because access isn't just about technology, it's about support. If you take one thing from this discussion, let it be this. Before you launch anything, ask, can someone use this without help, confusion, or frustration? And if the answer is no, here's your opportunity. Because bridging the AI gap isn't about making technology more advanced, it's about making it more human, more usable, more accessible, and more real. Because the goal isn't just innovation, it's making sure people can actually benefit from it. I will leave you with this final thought. Technology doesn't create impact. People using it does. Leverage AI to maximize the impact on your life, your business, and your revenue. If you're interested in learning how to leverage AI, I'd love to connect with you. Please take a picture of this slide and reach out to me. Thank you for your time.
Thank you, Deborah and Dan and Jessica. Very good way to kick off our discussion today. I think we have everyone here ready to participate, and I want to get to the nitty-gritty of our conversation. So let's jump into our first question. Our first question is about accountability, and I'm going to ask Dennis Tran, board member of the Disability Justice Steering Committee with the American Public Health Association, to lead us off. So Dennis, here's the question. What is one question that community members or advocates should always ask before a new AI tool is introduced into their community or care setting?
I would say like the first question community member or advocates should ask is who was in the room when this was built and who was left out, because AI reflects the assumption, data, and priorities of the people designing it. So it's not people just like, it's like I mentioned in the previous presentation, is like if you're not building something with intention or you're not considered the human factor to it and the community you're designing for, you're often leaving out a lot of different people. And as someone who grew up navigating systems built with various intersectional identities and facet identities of being part of different marginalized community groups, it's definitely very difficult to see how technology excluding so many different people who are queer, partially blind, low income, and even neurodivergent folks as well, and just how technology is just leaving out a large community group. And right now, adoption is moving faster than literacy and governance have it, and studies have shown that 92% of students already using AI tool, for example, but many institutions lack formal AI policy. So parity means that access should means more than access, but it means that disabled people, caregiver, different people from marginalized community and voices should help shape the technology from the very beginning and not later as an afterthought or a feedback.
Very powerful place to start. Thank you, Dennis. Does anyone want to build on that piece from either a healthcare or academic perspective?
I can chime in. I completely agree with what Dennis is saying. I mean, my presentation was built on the equity lens of, making sure that all people are included in the conversation and making sure that when we are building these systems or like ones that are marketed, that we really aren't sitting at the table to be part of that conversation. Entrepreneurs, for example, that are building these systems, Replica, Character AI, Know Me, we're not part of that conversation. So in those cases, how can we really create guardrails to help, because they're being marketed towards our youth? So I would even take that a little step further in that aspect.
I can also add on the conversation by really taking one step backward and see the lessons learned from previous technologies who really AI is based on, for example, with Microsoft Office, with PDFs, with the digital technologies related to what we saw is really this devastated effect on disabled communities in general, that these companies, after many years, after many lawsuits, they started adding patches to think about accessibilities. But the harm is there. I can give you an example. One of my friend with vision disabilities who last year was forced to quit his graduate degree because of inaccessibilities, because of the PDF, the books, the websites, none of it was accessible for him. So there is an important lesson learned from the past to really understand the harm that is being put on a community who already faces so many barriers. And yeah, my fear is that we are going 180 speed, leaving so many communities behind. And when we start filing lawsuits, then we put these patches, but then turn around and say, well, you know, the challenge is the community, is the people with disabilities, like they are the problem, not the technology itself, which creates a new type of stigma, new type of barriers.
Beautiful. I love that. Thank you so much. Let's move to question two. Question two gets at the practical realities of where people are geographically, technically, in terms of their daily lives. I'm going to ask Mustafa to start, and then Dan to kick off, and then we can open it up with more time after that. So, Mustafa, the question. Many AI tools depend on high-speed connectivity and digital fluency, which create barriers for rural areas and older adults. Beyond just simply the interface, how can we build tools that are functional in low connectivity environments or for those who have specialized needs, such as caregivers?
Absolutely, that's a great point. I think my colleagues already raised the issue of who are in the room when these AI tools are being designed. Who are the making decisions? Who are are these AI being tested before it's launched or after launching it, just like what happened with Microsoft, that, oh, now we are seeing the problem after 30 years of harm. So I think we need to stop designing AI only for the ideal users that will profit the company in a short period of time, but then there's going to be a harm. There's going to be this what's called digital divide. And then we are leaving communities who are already at risk, communities with low digital literacy, low in English proficiency. And really what that means is that, we are creating harm that will basically contributes to further dividing the society into those who are benefiting from these technologies to those who are paying the price. Again, I want to go back to the points that earlier my colleagues emphasizes that we need to make sure that people they're being consulted, being engaged at early stage of the development, not later on.
Yeah, I would agree with that as well. I think for me, probably one of the most important things with AI utilization is let's start with the problem, not let's start with the tool and how can we use it. I've seen people sort of forcing AI into areas that you never felt like you needed to use it in the first place. But obviously, if your issue is that you're trying to reach people with, low broadband access, maybe AI is not the tool for this solution. I will also get on my digital accessibility high horse and talk about inclusive design is not just for people with disabilities. It actually, improves access for everyone. So if you're providing transcripts for your streaming video or audio, people can read that transcript if they can't load the video. If you have alt text for all of your images that can't load on someone's page, there will be a text representation of what they're missing out on. So, this is a situation where I think inclusive design can really benefit everyone.
And I'd like to add, I would like to remind the audience to not let the lack of Wi-Fi or internet access or digital literacy prevent you from utilizing these free AI tools. Many local establishments offer free Wi-Fi services, like your library or your community center or maybe college, even Starbucks and Panera Bread and even McDonald's, to name a few. So it's a powerful tool, and there are some limitations in some of the rural areas, but if you can get to one of those locations, I think it will be worth it to adopt this tool.
Awesome. Amazing. You guys are great. I love it. Let's keep going. We're going to talk on question 3, which is roadmap for empowerment and adoption. I think, how do we move from passive recipients of technology to active shapers of it? And I'm going to ask Dr. Stansbury to lead us here, and then Deborah, Mustafa, anyone else who wants to chime in after that. Dr. Stansbury, the question is, we want to move from just using AI to using it as a tool for empowerment. What is the single most important step a community leader can take right now to ensure their neighbors aren't just recipients of technology, but are active participants in shaping its implementation and adoption?
Yeah, that's a great question. And, I presented a little short framework on how we get from access to agency. And I think, where we start is that initial preparation phase, right? So how do we prepare the people that are going to be encountering this type of technology to understand what it is, what it does, how AI, and I've noticed we're talking about AI in a negative sense, I feel like a little bit in this conversation, but I do think that there is benefits to AI, especially in the mental health space, that can, as long as we understand what those limits are, what the biases are that are built into the system, the cultural implications, especially in like the AI companion space. For me, and going back to something Dan said about problems, the AI companions were initially designed by entrepreneurs who were trying to help with the loneliness, right? And we have a loneliness epidemic. And what has transitioned from, we had social media thinking, that kind of gave us a free license to argue with one another, to call people out, bully, but also on a positive side to share things, right, with people that were at a distance. And now where we failed, I think, with social media was we just kind of let it go on its own and do its own thing, and not really understanding the implications of those that were using it, or that preparedness piece. Whereas in AI, now AI can be really insidious in the negative sense that you're going to have an echo chamber. So it's reinforcing everything you believe, right? And it's telling you all these positive things about yourself. And while that might seem good on the outside, it can work in a very insidious nature that could then almost make you forget that you're talking to a machine on the other side of the screen, right? So, but if we have that preparation and we have the education, and then we provide the access so people can experience it and learn it, right? Then we can get them to the agency piece, which is how do we really think about this in a collective, community-centered way to help us grow and advance. So I think it's a process, but I want to be clear that my position is not that AI is necessarily bad in this space. I think it really depends, right, on who's using it and how they're using it, and do they understand its authority and power that it wields without us sometimes realizing that.
Yes, and I agree with you, Dr. Jessica. I see it as a very positive tool. AI is a tool that can really amplify the capabilities of any task or project. And I think the single most important step a person can take to become more empowered is really to start with just small steps. Think about a simple task, daily task that you think could save you some time. I like to use this example about meal prep. Your kids are home and you can't run to the grocery store, so it's like you need to prepare a meal for your family. But what do you have in your refrigerator now that can be used? And so ask AI. That could be Claude, ChatGPT, or Gemini. They're all free plans. You take a picture of the ingredients in your refrigerator, in your spice cabinet, and your pantry. And I've done this. And so you just ask AI, I want to prepare a healthy meal for 4 people, let's say, using the attached current ingredients. So provide me with meal options, recipe, and instructions to prepare this meal. You attach those pictures and then you press enter. And believe me, in 5 seconds, AI provides you with several healthy meal options for your family with all of the ingredients you already have on hand. It's really amazing. So I believe that utilizing AI tools for your daily needs and seeing real results provides a sense of empowerment and adoption. People begin to say, oh, so what else can AI do to make my life easier? So I think that's the key, is just taking those simple steps to use the tool. And people will become more comfortable with it and adopt it on, some other tasks or projects that they have.
Yeah, I can add also to this quickly as well. I think it's like to add the conversation of like it's not just about using AI, but also as community leader to be able to create a space where it's safe enough for people to question the technology and not just consume it. Because oftentimes people of immigrant or people like who are newer technology or the community caregiver, they often lack the technical knowledge, but they're unfamiliar with like these technology to kind of participate in conversation. And oftentimes when I kind of like hear my own parent generation, it's like there's a lot of fear, there's a lot of anxieties, but how can you create a space where people can ask questions to understand more about AI and understand the impact of AI in terms of how it impacts our life, our work, healthcare, education, relationship, and so forth. But it's also to kind of understand the implication of like AI is a benefit. It can help you so many different ways, as mentioned my colleague here. But oftentimes, like there's not a lot of spaces where it fosters that learning environment that can actually empower them to actually utilize it, especially people with disability who maybe not be able to like prompt the AI in traditional way where AI is designed that way. So how can it bring people in to the conversation to co-create these solutions so that there's also different format, different way that adapt to the individual and their needs to kind of empower them to use AI, because oftentimes like it's not a one size fit all solution, and we need kind of a universal approach to AI to kind of help allow people to equal have access to it.
Yeah, I agree with that. I think for me, I feel like my presentation is a little bit, on the negative side with AI. My concern is less so about, people who are using chatbots or things to, produce things for themselves. It's more so from the perspective of someone having to use a product that was built with AI, or seeing that, not having the power to change that, whatever they're facing. I think sometimes, we get into trouble when we start using AI for things like, job interviews and people, not being selected for positions because they don't make eye contact with the interview, chatbot or their being lower scored based on things like that, or how their face looks, things like that. But I will say, I work with a lot of people in the blind and low vision community who are AI powered users, and they are very excited about it. There's a lot of advancements in things like the Ray-Ban, the Meta glasses, so that people can read menus or go grocery shopping and describe what is in the aisles. And I haven't even talked about autonomous vehicles. That's a whole other subject. But I will say, in the blind and low vision community, AI is not seen necessarily as this doom and gloom situation. So that that is something we do want to talk about.
And
I
I
can
think
add also a couple notes on that. I mean, the accessibility brings us innovation. A lot of technologies that people in general use comes from accessibility, using tech, like the theory that so many innovations just, the general public use it. But I also talked a lot about the negative side, which I want to emphasize it again by, my fear is that the inaccessibility exists in a wide range, and as these technologies like going so fast, and especially what concerns me is that, the recent federal digital accessibility rule was going to get into effect in April. They had to delay it because they know the gravity of inaccessibility in digital world. And they know that if they enforce the rule, that there is going to be so many lawsuits. And I hope this is an opportunity for these companies to take accessibility seriously.
Thank you, everyone. Unfortunately, we are at time. This is an incredible conversation. I think it's the conversation that changes things. It's not really big policy announcements or press releases. It's conversations like this with people who care and people who know communities they serve. Thanks for sitting down together and answering some difficult questions. But I think we were left with some incredible insights. I know we're at time and we don't want to keep people from lunch, but I know our panelists are willing to answer any questions in the chat that you may have. So if you're interested in that, feel free to put some questions in the chat and they can answer. But thank you again for this conversation. I wish we had another hour to continue. But
you had a chance to recharge. For those who just joined us, thank you for coming. And as a reminder, we ask that you please, if you can, please feel free to interact with our presenters using the chat or the reaction functions. Also, please make sure that your Zoom name reflects what you used for your registration. If you're interested in receiving copies of slides, this will be at the discretion of each presenter, as UMD does not retain ownership of the materials. You will see a disclaimer at the bottom of each slide indicating whether a session If a session is not marked for recording, it will not be included in any video posted on YouTube. So now let's dive back into our fantastic lineup of speakers. Up next, we have a presentation on practical AI integration for health education, enhancing learning with human-centered technology, brought to us by Quisha Umemba. Quisha Umemba is the CEO and founder of Umemba Health, a training and consulting firm that helps health-focused organizations and educators integrate artificial intelligence into learning in ethical, human-centered ways. A registered nurse and a public health practitioner, Quisha brings a rare blend of clinical insight, workforce development expertise, and instructional design experience to her work. She is known for translating complex technology into practical tools that support educators, strengthen mentorship, and improve real-world health communication. Grounded in equity, accessibility, and care, her work focuses on using technology to enhance rather than replace the human relationships at the heart of effective health education. Please join me in welcoming Quisha Umemba.
Thank you so much, Nerese. Am I able to share? Let's see. Wonderful. Give me a thumbs up if you can hear me good, if you can see my screens as well, my slides. Excellent, wonderful. Hello, and thank you, everyone. Thank you so much for attending my session. I am Quisha Umemba, and today we're going to talk about practical AI integration for health education. Before we go any further, and you'll see I like to give plenty of disclaimers. First of all, I want to speak to the heart of this session. I will admit I have been guilty of preaching the AI gospel, saying you better get on the train or get left behind, right? But this session is not about chasing technology today. It's really about protecting the people that are doing the work. And so if you are an educator, you're one of the people that I want to protect. And I want to also help improve how we do this work, how we teach, how we learn, and how we connect. You probably already know, just as well as I do, that AI is already showing up everywhere. No doubt that's also in health education and health in general, just in general. So whether we plan for it or not, we are using AI across content creation and planning and communication. And so the real question is not if it's used. We know it is being used. It's how it's used and how intentionally it's being used. Today, I am going to position AI as your teaching assistant, not as your authority, not as your replacement. And by the end of the session, I'll give you a simple roadmap that you can adapt to your role as an educator, to your learners, and ultimately to your community. So before we get into it any deeper, I'll share a little bit more about myself. So again, my name is Quisha Umemba. I am the CEO of Umemba Health. I like to say we are an AI-powered public health training and workforce development agency. We help mission-driven organizations transform knowledge into scalable learning assets by leveraging AI tools effectively. And I do like to say we are the missing piece of your AI puzzle. Our services at Umemba Health include, of course, AI literacy training, AI integration consulting. We do a lot of learning design and course creation, workforce development, and we're known for our community health worker capacity building. I am a registered nurse of 22 years. Where does the time go? And happy Nurses Week for any of my fellow nurses that might be out there as well. I am a public health practitioner. I'm a community health worker instructor. And now a certified AI consultant and AI trainer. And I say all those things and share all those things so you know I've spent my career between the bedside, in the community, in the classroom, and now in the technology layer that really is reshaping all of these areas. So everything that I'm going to share with you today, and unfortunately I can't get too deep, but what I am going to share with you, it does come from real lived experience. So, a real educator with real learners in a real classroom and working in real communities. So with that said, here's a couple more disclosures. The views that I share today are my own. They don't represent those of the conference coordinators. Takes what is useful, leave the rest. I won't be offended in the least. And then the most important disclaimers I have to give you is about how this presentation was created. And so we pride ourselves on being good stewards of AI at Umemba Health. And AI stewardship is the practice of using AI with care and with intention and with accountability. And so with that, I have to give you my AI transparency disclaimer and share with you that parts of this presentation were developed with the support of AI tools, but every example was reviewed by me, was edited by me, was guided by me in my lived experience and my professional expertise. And so if you like how that feels and what this looks like, I always invite organizations that want to go deeper to visit our website, umembahealth.com, where you can download our ebook, AI Stewardship, How to Use AI Without Compromising Trust, Values, or People. All right. Now, here is my promise to you. By the end of my session, you will understand how to integrate AI as a teaching assistant, not as a replacement. And again, I'm going to leave you with a simple step-by-step roadmap that you can adapt your programs, your roles, and your learners to, so you will leave with one concrete next step. You might leave with more, but at least one concrete next step. All right, so this is our agenda. I'm going to open up talking about the educator's dilemma and why your learners need you more, not less. We'll talk about a term called human in the loop and what that actually means in the context of health education. Then we'll spend a lot of our time at the heart of our talk with Angela. She's a community health educator. She's going to help you understand the theory that I'm sharing with you in more practical terms. We'll connect that to health outcomes, and then we'll close on that roadmap that hopefully you can start tomorrow in your work. So let's start with our dilemma and why your learners are feeling the way that they do. And thank you. I forgot to say that I love engagement in the chat. I keep my chat open. So thank you for that enthusiasm, Catherine. All right. So let's start with this dilemma. You know it. You feel the pain as much as I do. First things first, educators are overwhelmed, right? Admin hours keep climbing, and in the hours in the day don't, right? You've got content updates, you've got reporting, you've got the sheer volume of learners that need to be taught. And when you're being pulled in 101 different directions, guess who gets the leftover version of you? Your students, your learners, right? That's one issue. On another hand, we've got learners that are disengaged, not generally because they want to be disengaged, just because they're flooded with information, right? Flooded with information from all types of modes and avenues. And when we talk about specifically health content, they're really starved of content that they can trust, content that has some depth around it, right? And there's a lot of disinformation and misinformation out there. Then we are also struggling with teaching programs that are having a hard time scaling for a number of different reasons. Could be financial, could be, organizational, but often most organizations are struggling to scale because they're burning out their educators. And educators are not the only ones that are feeling this. The learners are feeling this too. So on the one hand, you have limited capacity, you have time constraints, you've got administrative burden. And on the other hand, you have something that we cannot afford to lose as educators. We cannot afford to lose trust and connection. So when we look at this paradox, right, most of us, if not all of us, we need to educate more people, but we cannot do it at the sacrifice of human connection. According to the World Economic Forum, by 2030, more than 1 billion people, billion with a B, by the way, will need to be reskilled or upskilled. Okay. And at the same time, you probably know as well as I do that the global demand for high quality learning content is skyrocketing. Not only is it skyrocketing, but the pace in which we're being asked to produce this high quality learning content is skyrocketing. So your goal as an educator is really to offload the low value burden without breaking the relationship that makes education work in the first place. So yes, we must reach more learners, but never at the cost of the trust and the connection that actually makes learning stick. So the question isn't, should we use AI? I'm not going to say should we. My answer is yes, we should be using it. It's a tool at our disposal, right? But for me, the question is more so, what can we use AI? How can we use it? What can it carry so that we can keep doing the human things that we know we need to do for our learners? Now, I want you to take a moment and answer a question for me. If you could hand off one administrative task or organizational task, doesn't matter, what would you hand off? And where would you reinvest that time with your learners? So if you can hand off one administrative task that you're asked to do every day or every week, what is that? And then where would you reinvest that saved time with your learners? I'm really curious. I'd love to see your responses in the chat. And the reason that this is helpful is it's important for us to understand that AI should not add to our workload. It should remove weight. And the first thing we have to do is identify, well, what are those tasks we hate to do? What are those tasks that take up so much time? And what are those tasks that take us away from our learners? And I apologize. I lost my voice about a week ago and it has not come back. And this is about as forceful as I can make it. And I hope it makes it the whole 45 minutes. But I am going to be drinking water from time to time to help save my voice. So my apologies if you're unable to hear me that well. All right, so we've got some responses that are coming in. Oh, Julie said, clear the thousands of spam and subscription. Oh, let me make this a little bit bigger so I can see that as it's going up, that I have in my personal email so I can better filter new and important emails. Oh, hey, I can definitely do that. Chin New says probably scheduling. Hey, I can do that too. Making a spreadsheet, documenting progress notes. Sounds like a great job for AI. Thank you so much, Katia. Following up with community engagement related to registration for program and events. Sounds like a great automation task for AI. George says contacting new clients. Just depends. Humans may want to do that the first time we contact them. Okay, that's great. Thank you. And if you have any others, you can put those in the chat as well. I'll try to remember these and maybe come back to a couple of them as we're doing, as we continue the presentation. All right. So here's the reframe if you're not already doing this. And I think that many of you may be doing this already. Reframe your mind so that you remember AI does not solve human problems. Okay, let's just say that first and foremost. AI solves capacity problems. The things that you just put in the chat, that's what AI solves. But it only solves capacity problems when it is designed well, okay? Because AI is an optimizer. If you have crap, it's going to scale crap, right? It's going to optimize crap. But if you've got organization, I should have said chaos. I shouldn't have said crap. Sorry. But if things are organized, it's going to scale organization, right? So when you're using AI as your teaching assistant, just remember it is not your replacement. It is there to help you reclaim the time, the scheduling, the clearing out your inbox, the documenting progress, engaging with your community. But maybe not the first time, maybe re-engagement, right? All those things you just put in the chat box, it's there to help you reclaim your time so that you can fully show up. Yes, create PowerPoints, build clients, prepare content for your website, all of those things. And the moment we stop defining the role clearly is the moment that AI is going to start making decisions that belong to us and our learners. Okay, so that is the reframe. Now, the next concept that I want you to remember is HIIL, or human in the loop. Human in the loop means exactly that. I mean, it describes itself. In this context of our conversation today, it's where AI acts as the teaching assistant while humans maintain ultimate control. And so I've delivered it here in a three layer model for you to understand. At the core is human judgment. This is the anchor. This is your values, your ethics, your cultural context, your lived experience, ethical reasoning. This is your relationship with your learners, and ultimately all final decisions, right? Layer two is the engine. This is where AI is supporting you, drafting, organizing, summarizing, personalizing even to your learners, creating those scenarios, right? This is because AI is fast, it is tireless, it doesn't need to sleep, so it's useful for heavy lifting that requires a lot of volume. And then the outer layer is your environment. This is your learning workflows, your classes, your programs, curriculum design, learner support, lesson planning, all of those things. And so when you look at human in the loop, you can see you can't have everything unless you have the human judgment at the core. So that I'm going to keep driving that home because I want you to understand. And people ask me all the time, should I teach using AI? My response to them is, where are you going to stay in the loop? Yeah, of course you should, but where are you going to stay in the loop? Because AI helps us do the work, but it doesn't decide where the work should be if that makes sense. Okay. Now, I started off this presentation providing my AI transparency disclaimer at the beginning of that talk, because one of the things that we've done is Remember Health with our internal policies is we've said this is how we use AI in our organization, and this is where the human is going to come in. I want you to do that as you start this work where you're going to incorporate AI as your teaching assistant. You can look at it as separating it in two groups or in two trays. And so tray A is really where AI shines. It's high volume, it's low context. It's stuff that takes forever. It takes you away from your class and your learners. It takes you away from the things that you need to be doing, summarizing, sorting, drafting, adjusting reading levels. Thank God we don't have to do that manually anymore, right? AI is great at these things. But tray B, this is the human aspect of the work you should be doing as a health educator. These are low volume, but they're high context tasks. These are things like mentorship. This is where cultural nuance comes in. This is where emotional support, building trust with your learners, ethical or clinical judgment. AI is completely wrong for all of those things. And this is where I see many people, not just educators, but many people in general, they flip it. They give AI the human moments and they hand do the busy work. So take inventory of what AI does really well and what you as an educator do really well. And I promise you, as long as you get that right, you're going to feel the difference and your learners are going to feel the difference too. So that's the shift that I'm talking about making here is letting AI reabsorb the repetitive pieces so you can invest in what only you can do as an educator. There's a matrix that I have given you as an example too that you can help do this. This is kind of what we use internally, where we have on one side where AI, what task AI can do, what task the human or the educator can do. And guess what? Sometimes AI can do both. And the educator can do both. And so that's where our human judgment comes in and saying, you know what? We're going to let AI organize and we're going to let it take the first draft and we're going to let it do the brainstorming because we need our brain power and we need to save time, right? We're going to let it sort out the emails. We're going to let it draft the PowerPoint presentation, just like the one that you're looking at, right? Because I don't need to spend my time doing that where there's so many other important things. And I got 101 people enrolled in my courses that I need to spend time mentoring and pouring into them. Okay. So a matrix like this is going to protect your role, it's going to protect your learners, and it's going to help build trust ultimately. And we know that trust is built through people and relationships, not through systems and not through technology like AI, right? Now, I'm not beating up on AI. I'm a big proponent of AI, but I do believe in human-centered AI practices. Now, I've given you a lot of theory. Now I want to make this more practical for you. So I'm going to invite you to meet Angela with me. We're going to go over Angela's case. And we're going to follow her through one full workflow as she prepares her learners to lead culturally tailored diabetes education in their neighborhoods. Now, of course, I do a lot of work in public health and community, and so the case study is going to reflect that. But try to imagine what you do with your learners and what that may look like with a similar with a similar workflow. Sorry. All right. So Angela is a community health educator. She trains community members to facilitate diabetes education sessions where they live. She has 50 new learners this cohort, a ton of learners. She has handouts and facilitator guides that have not been updated since 2022. She has an influx. Somebody talked about their inbox, right? She has an influx of emails on tons of questions about what to do and am I prepared and what if this happens and what if that happens. And her goal is not only to develop this content, but she wants to send every learner out confident, prepared, and rooted in their community. And she wants to do all of this without burning herself out because she's got to get this cohort ready and out into the community and ready for the next cohort. So what Angela does is she completes 4 steps across one workflow. As an educator, you already know the first step is to identify the learner gap, right? So she does that, and then she assigns the role of teaching assistant to the AI tool that she's using. That can be the tool of your choice. I'll talk a little bit about that in a little bit. And then she does a human review. And the next step is to personalize each learner send off. And so if you look at these 4 steps across this one workflow, you see that AI absorbs the first 2, identifying the learner gap, and she's going to take that information and it's going to do something with it. And then assigning the role, it's going to absorb that. But then the last 2 steps, that's where she comes in, the human review, and then delivering that personalized information directly to her learners. So let's take a look at what this looks like. So we're going to bypass the first step. We're identifying the learner gap. We know we've got outdated facilitator guides. We know we've got a ton of frequently asked questions from her learners. So this is what Angela's going to do with step 2. She's going to assign her AI tool as an assistant, as a teaching assistant, right? So there's one thing I want to mention here when we talk about prompting, and this is going to be very short, right? So you can do a vague prompt with something like "help me with my class" or "help me with my diabetes class for my learners," but I promise you, you're going to get very generic, very inaccurate, off tone, and most of the time unusable outputs. Okay. So at the minimum, you need a scoped prompt that has 3 parts, right? We actually teach a few more than that, but at the minimum, you need a role that you're going to give your teaching assistant. You need a source and you need an output. So you need to tell it what it needs to give you, right? And so you can see here that Angela is going to say something like, "You're my teaching assistant. Here are my curriculum notes plus the 12 most common frequently asked questions from my learners. And now that you have this information, draft a 1-page study guide in plain language at a 6th grade reading level." Okay. And so when she does that, it produces a unique, tailored draft that is ready for human review. I'm going to actually show you what this looks like. And because I can't do it in this PowerPoint presentation, I'm going to switch my view here really quickly. And I'm going to actually pull up the platform that I created this in. So let me reshare. And I'm going to go to screen 1. And let's put this in a presenter mode where you can see this. All right, so I'm going to hit play here and we're going to see what happens. Now, what you're watching on my screen is Angela is prompting her AI to draft a learner-facing facilitator guide. Okay, I'll reset and play that again. And she wants her learners to be able to run their own session. So again, she says, "You're my teaching assistant. Here's my facilitator curriculum and the 12 most common questions my learners are asking as they prepare to lead their sessions. Draft a 1-page learner-facing guide titled How to Run a Culturally Tailored Diabetes Education Session in Your Community," right? Plain language, 6th grade level, speak directly to the learner as future facilitator. And so that was Angela's prompt. In the second section, you see the AI draft, which is not what we're going to use, right? You never use the first draft. And what you see in step 3 is the human checkpoint, the guardrails that Angela's actually put in place. So she didn't have to start from beginning developing this document, but because she knows her audience, her learners, she's going in and adding her own personal touches as an educator. You see, she's changed some terminology here. She puts in a special note from herself. You already know your people. This guide is here to help you trust what you know and add a few tools, not replace your voice with a script. And so where it's giving her some recommendations, I'll just go here to step 3. It says use foods your learners actually eat. And so she crosses out as your examples and says rice and beans, collard greens, tortillas, jollof, whatever is on their table, skip the generic plate diagram, right? So this is how you use AI. This is what you're going to do. You're going to cut what you don't want out, cut what doesn't apply to your learners, and you're going to add what you know your learners need. Now, I am showing you how to use AI as a teaching assistant using a prompting feature, right? And it's so funny. This is Claude, which is what I use most of the time. But if you see here on the top of the screen, it says chat.openai. I thought it was so funny that I actually used chat as an example and didn't use Claude since I designed this with Claude. But one of my favorite ways to create a teaching assistant is to use a custom feature. So if you use ChatGPT, that's going to be a custom GPT. If you use Claude like I do, that's going to be a custom project. If you use Google, that's a gem. If you use Microsoft, that's a Copilot. And the way they work, for instance, inside of inside of Claude, you use projects. So I will put my all of my files, my syllabus, my curriculum standards, my rubric, my class roster, my outline, anything pertaining to my class, I will put in a project. Then, as I engage with that particular project, I no longer have to say, you're a teaching assistant. I no longer have to tell it my teaching style. I no longer have to tell it the context or the topic because all of that is in a project. So, for instance, I have a project called my AI powered curriculum design course assistant. And so I have trained it and I have filled the knowledge base or brain with so many handouts and PowerPoints and just all kinds of information. So when I want to create an AI course or curriculum, and it's around AI, so this particular one is about helping me create AI content faster for my audience, right? I don't have to start with this scoped prompt. I just go directly to my project. I hope that makes sense. So I don't have time to go into it in this project, but I wanted to give you an example of what this looks like and how you take what AI gives you and you use your lived expertise and your lived experience and professional expertise to make it more applicable to your learners. Okay. I'm going to get back over here to the presentation. I'm going to close this screen and pick my notes back up. All right, thank you for that. Okay, so you notice with the checkpoint that Angela does not just hand AI the draft that it gives her, right? She intervenes, she fact checks against clinical guidelines, if that's what you're teaching on. She fact checks against cultural nuances. Her learners are going to teach from that. And so she wants to adjust the tone for the communities that they'll serve. And she only injects what she knows, only what she knows about who is in the room, about her learners, about how they're going to be engaging. And so a question that I want you, you don't have to put it in the chat, but as you're thinking about doing this, what does your learner need from you? Or even from your learner's community that AI could never give them? That's really where you shine as the educator. So I have a really good question in the chat, and it says, do you think one tool, Claude, Copilot, ChatGPT, etc., works better than the next? Personally and off the books, yes. But since we're professional, I am AI tool agnostic. Whatever you can use, whatever you can afford, whatever is in your budget. And ultimately, it's how you train it, right? It's like when you're using a prompt. If you put a bad input in, you're going to get a bad output. And so I think it doesn't really matter the tool. It matters what you put in the brain of that, in the knowledge base of that custom GPT or GEM or Copilot or project. So no. But if we were talking personally, I would tell you what my favorite tool is, but you may be already able to figure that out from this presentation. Okay, so last thing, not last thing, but I want to give you this, and then I'll read that comment in the chat. Angela sees in doing this in our case study that she's able to reclaim time with her learners. And so where she was spending 12 hours on admin and drafting per week, she's now spending only 3 hours doing that. Where she was spending only able to check in with 3 of her learners every cohort, she's now checking in with 42 of her learners for a cohort. And whereas her facilitator guides and her handouts and educational tools had not been updated since 2022. She's able to do that monthly now. And the reason why I thought it was really important to have this kind of slide in this particular presentation is because this is what it took for me to really be sold into using AI. I didn't share it in this presentation, but when I was introduced to AI 3 years ago, I was so against it. A friend of mine, another nurse entrepreneur, showed it to me, and I said, I will not. I am an intellectual. This is cheating. Every book I've read, every course I've developed, I have done that through my own efforts, through my own blood, sweat, and sometimes tears when I was in school anyway. And this is just, I didn't understand at the time. Now I know I was scared of being replaced, scared of my intellect being replaced. But I just said, this is cheating. I don't want to do this. And she said, Quisha, you remind me of our parents when the internet came out. She said, tell me how your parents are when it comes to technology. And I thought, well, my dad's a retired teacher and he probably can't even turn on and off a computer. Or that might be as most he can do because they didn't use computers when he taught, right? And then I thought about my mother, who thankfully DVD players are not a thing anymore, but she didn't even know how to use a DVD player. She would say, put this in, let's watch this DVD. Like, she's that technology averse. And so that's really what encouraged me. I thought, this movement is bigger than the internet and I cannot get left behind. So when I started using this, and at the time, it was taking us 20 hours to develop one CE, so continuing education, one accredited hour of net new content, roughly about 20 hours, right? And this is after developing courses and curriculum for several years as a nurse planner. And so when I started incorporating AI into our workflow, everything from the literature review, the needs assessment, everything, content develop, everything, we went from 20 hours of 1 hour, one accredited hour of CE to 4 hours max. And that is the design, the facilitator, like everything. And so I didn't put my hours in here because I'm doing a case study with Angela. But when I actually looked at how much time I was saving, how much time I can now mentor with my students, provide mentorship, to my students, that's what really sold me on it. And so hopefully, as I'm sharing this experience with you, that's what sells you on it as well. And thank you, Badimi says, Claude better understands human connection. ChatGPT works more for creativity. And I am going to agree with that as well. All right. Wonderful. Okay. So let me look at my time. Oh, I'm actually doing really, really good on time. All right. I want to connect this back to the community. Because when learners are prepared, communities feel it, and better supported educators raise up stronger learners. Okay, so Angela used AI to prepare her learners. She equipped them with plain language guides. She rooted every lesson in the learner's own community. She followed up with almost every learner. 42 out of 50, that's almost unheard of. She refreshes the learner curriculum monthly now, not yearly. And actually, it had been several years since it was last updated. And all of those things that she did allowed her learners to be able to spread accurate, plain language health information, which then allowed her community members to ask better questions of their providers at their appointments. This in turn builds trust in our health systems and stronger follow-up on care plans and on care plans and how people are actively engaged in their own health across the community. I call this a reallocation loop because AI is absorbing the admin, the educator is getting time back that they get to reclaim in their schedule and spend with their learners. They are reinvesting that time in learner mentorship and development, and learners are stepping up. And when the learners step up and they're more confident, they're more prepared, the community feels that impact and health outcomes are improved. And that loop just continues on and on and on. It runs again and again. So here are three commitments that are really non-negotiables as you do this work. And even though it applies to everybody, again, the context specifically is here as educators and specifically health educators. Ethics and equity is first and foremost. Every output is checked for bias, is checked for misinformation, is checked for hallucinations and confabulation before it ever reaches a learner. Okay. Second, AI supports, humans decide. People get so frustrated because they say, I tried to use AI and I got rubbish and da da da. It's never supposed to be a one and done. AI is a really good first draft, right? But it's never a one and done. And then the third non negotiable is the educator learner relationship is the work. That connection, that human connection is irreplaceable. Everything else is extra. Everything else is scaffolding. And so if you hold these three at the core of your practice as a health educator, you won't get this wrong. Hopefully, you won't get this wrong. All right. So I promise you, I would leave you with a simple roadmap that you can start. Alexa, stop. Sorry. A simple roadmap that you can start tomorrow if you're not already doing this work. And the first thing I want you to do is identify one bottleneck, one task that drains you and it really stops you from showing up as much as you want to with your learners. Okay. Don't try to overhaul and do everything at one time. And then I want you to test by training an AI teaching assistant. Doesn't matter what platform you use whatever you use every day, what you're most comfortable with right now, but train it, okay? You can start with a simple prompt. Your teaching assistant, this is the class I'm teaching, this is what I need, give me an outline, whatever. Or you can build a custom tool where you're telling it, this is my learning guide, these are my notes, this is my evaluation from the last time, whatever you want to put inside of that brain. And then you want to set your guardrails. I call it your golden gate. Nothing reaches a learner without your review. So that is your roadmap. One bottleneck, one test, one checkpoint, and then you can see if you feel a difference. I definitely think you're going to feel a difference, and your learners are also going to see and feel a difference as well. Okay. So, what step makes AI your teaching assistant tomorrow? Those three steps that I gave you, but also if there's something else that you're thinking about, feel free to share that inside of the chat as well. And I want to open up the chat at this time for questions. And I think I have one question already in the chat. So anything I've shared with you today, any questions you have, please put those in the chat and I'll answer those at that time. Oh, Katya, what a beautiful question. So she says, does your AI not know about visual accessibility in making slides? These slides are not readable. And comment, question and comment. The font size of the text is impossible to read. I have to zoom in and out. Okay, Katya, thank you for that. So it's a beautiful question because one, we do want to make sure we think about accessibility. If you go to Member Health and go to the AI Training Innovation Suite, I have a custom GPT that does just that. Okay. Two, I am human. These slides were literally finalized an hour ago. That's not an excuse for that. But I will say I did not run these slides through the custom GPT that's in the AI Training Innovation Suite. There are personal things going on. I have been sick and I have a 9-month-old. Again, that is not an excuse. So, as an instructor, I take all of that feedback from my audience, from my participants, from my learners, and I use that to make my presentations better. So, Katya, thank you for that. Yes, you are supposed to make sure you check your accessibility. And I know that as a trainer and educator, which is why I've developed tools to do that. I apologize that I have neglected to do that in this case. Okay. Thank you for that. Now, if there are any other questions, please put them in the chat because I have 6 more minutes, which is a rarity because I never have time for presentations. But if you have any questions, please put those in the chat at this time. And if you would like to connect with me, please don't hesitate to do so. Here is my direct contact information. as well as our website and our virtual campus. Our virtual campus is Umemba Health Academy. And so you can check out some of our courses and things there if you're interested in learning more about AI as well. I will leave you with this. AI, again, is your teaching assistant. It is not a replacement. You are the educator, and your learners are the point. Okay. Catherine says, um, or communicate to their instructor challenges they experience with a particular assignment. I'm so sorry. If you could rewrite that, Catherine, I want to make sure that I read your question or your comment. Oh, okay. Her full question didn't post. I'll give you time for that as well. Okay, guys, so we still have more time. Thank you so much, Sally. Yes, the ebook is available, umembahealth.com. It's on the landing page where we talk about AI stewardship. So please go and grab that as well. And I'll turn it back over to you, Nerissa, I'm sorry. But I also want to make sure that if there is a question or comment, that I can address that before my time wraps, because I do have 4 minutes left.
Yeah, absolutely. Thank you again, Quisha, for coming and being here with us today and for providing us this engaging and informative presentation. As Quisha said, we are allowing you to go ahead and ask any final questions for the remainder of her time before we go to our intermission. I'll also, and if you would prefer to raise your hand, I will give you access to speak if that's easier.
And I'll also make my slides available as well, Nerisse. So I will send those to you. You're welcome to share those out if you like.
Awesome. That's great. Thank you so much. Okay, we do have someone raising their hand. I will ask. Okay, Catherine, I'll ask you to unmute now.
Hello. Thank you again for, just informing us about this topic. It's been a more recent interest of mine as I see more people, students using it and find myself using it more. My question from earlier was more people want AI to be more humanistic, so emotional versus sterile, stoic, generic. Um, Thinking that that will improve the response from AI. However, one of the things that I've read is that, and also I think it's just something that we know, one of the causes of bad decision making in humans are when emotions are involved. So do you think that it would be better, we would get better responses from AI, and from AI if we use critical thinking more when structuring what we need versus like just giving it a prompt? Like I'm trying to help like students understand that they still need to critically think while using AI.
Absolutely. And I think there's going to be a little bit of critical thinking skill decay because of AI. Um, but yes, we certainly need to provide more context to it. I want to go specifically to your question about emotions. I'm going to say it depends on who your audience is and the information that you're sharing with them. Often, I will just prompt my AI just to give it the feedback because I know during the human review, that's where I'm going to put Quisha's spin on it. And there's a certain way that Quisha talks and a certain way that she writes, right? And so that is why
Right.
that human review is so important. Now, I will also say I'm writing my third book right now, and I have trained the AI tool that I use on how I write and the way I come across emotionally and the supportive context or, the way I may respond to. I'll give you I'll give you a practical example. I was developing an email sequence and it's for women and it's maternal health focus, right? And it created the emails for me. And I said, when I speak to women, I'll say, hey, friend, hey, beloved, hey, love, how are you doing? Right. And so I tell it when you start an email, start by saying one or the other. When you end the email, I'll say in love, in faith, in trust, something like that, Quisha, Umemba, whatever that is. So you certainly can train the tool that you're using to have that emotionality in there. But again, the human review is going to be so important to make sure it still sounds the way that you intend it to sound, like you or whoever it is that is prompting it. I hope I answered your question there, Catherine. there anyone? Okay, she said yes. Thank you. Okay, wonderful. Thank you. You're so welcome. You're so welcome. All right. Well, I don't see any other questions. I made it right to 12:45, Nerese. So I'll stop my share and hand it back over to you.
Awesome. Thank you so much. And yes, you made it right on time. We really appreciate you being here. So let me share my screen really quickly. All right. We are now at our first afternoon break of the day. And this afternoon break is going to last for 15 minutes. If you cannot stay on, it is now 2 o'clock, so we will proceed with our conference agenda. I'll go ahead and ask our next session panelists to go ahead and turn on their cameras as we get started. So we're excited to continue with our incredible panel discussing the future of work in health, human and AI collaboration in workforce development. Leading this important discussion is Terry Mumm. Terry Mumm is Digital Navigation Program Manager at the University of Maryland Extension, where she leads statewide digital equity and workforce development initiatives. With over 20 years of experience building tech-enabled systems that bridge digital divides, Terry has secured millions in competitive funding and designed innovative programs that balance automation with human-centered service delivery. A 2022 Digital Inclusion Fellow and recognized emerging leader in digital equity by the National Digital Inclusion Alliance, she brings expertise in coalition facilitation, operational systems design, and preparing communities for the future of work. Our panel brings together an outstanding group of experts. Dr. Yulin Schwen is a distinguished AI scholar and associate professor in UMD's Artificial Intelligence Interdisciplinary Institute within the School of Public Health. Her work uses AI and digital data from social media to search trends to understand human behavior and inform public health policy. She develops AI tools that translate large-scale data into insights that can support decision-making and shape the future health workforce. Dr. Lakeisha Harris is Dean of Graduate Studies at the University of Maryland Eastern Shore, overseeing 33 graduate programs and leading interdisciplinary research initiatives. A former rehabilitation counseling professor, she focuses on workforce development in health and human services, including training programs in substance use, recovery, and applied community health. Dr. Kimberly Poole Sykes is a senior academic leader at University of Maryland Eastern Shore, focused on counseling, mental health, and educator preparation. She leads workforce development efforts that strengthen clinical training, accreditation, and access to mental health education. Her work centers on building a diverse, ethically grounded, and future-ready behavioral health workforce through community and systems partnerships. Dr. Joshua Sharfstein is a distinguished professor at the Johns Hopkins Bloomberg School of Public Health and former principal deputy commissioner of the FDA. His work is health policy and leadership focused on strengthening public health systems and preparing the workforce to navigate emerging challenges, including technology and AI. And our last panelist is Obiageli Nwachukwu, and she is a bioinformatics graduate researcher at Morgan State University, specializing in AI, machine learning, and health equity. She develops predictive models that improve clinical decision-making for underrepresented populations and explores how human-centered AI can support more fair and effective healthcare systems and tools. With that, a warm welcome to our panel, and I'll pass it to the panel moderator, Terry.
Thank you so much, Nerese. We'll get started. I'm so excited to be the moderator for this session. We have an incredible panel, as Nerese just described, so let's jump right in. We have a lot of conversation ahead and not nearly enough time for everyone, so let's get going. Our first question today is going to be about the evolution of tasks, and I'm going to kick off with Dr. Harris and Dr. Poole Sykes, and then we can hear from the rest of the panel after to keep going with this question. So with that, we hear a lot of AI replacing jobs, but the reality is more nuanced. Can you share a specific example from your field where AI is augmenting, not replacing, a healthcare worker's role? What does that human AI collaboration actually look like in practice?
Okay, thank you, Terry. Oh, go ahead.
Kim, you can start.
No problem. What I've been thinking about is how to use AI in a really ethically sound manner. And one of the things that we are becoming quite accustomed to is the efficiency of AI. And we have now been able to start this process of what can we tell our students so they know that we can use AI, it can still be grounded, you can still hear and see your voice. And one of those ways is to sort of manage AI with our paperwork, our processing, and gathering data. So it doesn't take away who that student will become as a counselor, but it will allow them to use some of the tools to make life easier. Case note management systems, pulling up theories and techniques. We still don't lose the I, the you, the we, but pulling all of those things together for efficiency is very important.
And my answer is similar in that, and some of the real world examples that I can think of as we talk to students, as we are training, as we are looking to provide greater access to our community on the use of AI and counseling techniques and things such as that. One of the things I'm wanting to train our students to understand when human intervention is necessary. And I think as clinician or counselor educators, one of the things we do is we try to train our students in that, yes, it's important. It can be used. It can help benefit the clients that you'll work with. But also understand that it cannot be a full replacement. And I think I was using an example last week of me going to the doctor's office and having to now sign paperwork that says, I understand that AI will be used to take notes. I think that's great. That frees up time for, our clinicians that we work with. But I would not want the AI diagnosing me or anything like that. And so it's important that we train our students in that way.
And kind of to piggyback,
Dr. Swen. Oh, go ahead. Sorry.
Piggyback and also say the other piece to this is knowing that AI will be used in those ways. It frees up so much more time for us to hone in on how important the human connection is.
I certainly
Awesome.
agree with that. I'm a pediatrician. And for me, when people ask me, what's the best part about being a pediatrician, I actually say it's the relationship with the parents, because you really have an amazing connection with someone about the health of their children. I love the children, of course, too, but like the ability to really say you're doing a great job to a parent and hear their hopes and fears. It's just hard to imagine AI ever really being able to replace that, because there are always challenges with kids, and having that relationship over time with someone is so important to be able to handle those challenges.
So it's interesting because obviously as a researcher in the field and then also just being, in the public and as a patient myself, yes, from the research aspect, I mean, there's so much potential for it. And on the theoretical side, it can really start to do tasks, for instance, organization and so forth. But from the patient side, I have to say, I really hate it. And I think that human connection is really important. I think we're losing a lot of that, to be honest with you. Like, I don't like going, I do not like going and, seeing a clinician and having to sign that AI is going to, scribe the work. I don't really have a choice whether or not it's going to, or else I'm not going to get care. I mean, do we have a choice in that type of way? And I've had it done, and I've had it be wrong. They've written up, the report to not be what I had mentioned. And so is the clinician actually looking like, you say that there's human in the loop, but are they actually, going through kind of the notes itself and making sure and double checking? So I do think it has that potential, but, in practice, I'm worried that it's already starting where we are already at the point where it's kind of being automated. where we're starting to shut off like cognition. And even I'm not just talking about like in the clinical area, like I'm also talking about research too, where you start being very dependent on the AI system. And so, how to ensure that, human connection still exists, I think is really important.
Just to chip in here, can you hear me? And on my own end, right, even coming from my clinical background, I could see how AI could just transfer the bias just across board and very, very easily. However, from a bioinformatics background, in my master's, right, my first semester we had an exam and we were in school till 1 a.m. And at that point, we kept thinking, this was a personal example, experience. So at that point, we kept thinking, what would have happened if there was no AI? That means the researchers would have just been in school. You can't, bioinformaticians, you have to run sequence data sets. So because in bioinformatics, we're handling transcriptomic data. So AI had allowed us analyze this data, gene expression data, much faster and much more comprehensively. However, while it can identify the patterns, right, it also identifies the biomarkers and potential disease associations across massive data sets. So for us, it's a beautiful experience because it makes this process faster, more trustworthy. However, one thing for certain is that the interpretation of all this data depends on your intellect, depends on what you know, depends on the human expertise. So even understanding the biological context, validating the findings, and to determine whether these insights, right, are actually clinically meaningful. So just like Dr. Yulin mentioned and other panelists, AI cannot with the evolution of tasks, right? AI cannot take over the place of the human. So at the end of the day, you still need humans that know how to utilize artificial intelligence to handle tasks and be able to help people.
And I would say as a counselor educator, and I was discussing this, in our previous talks, I'm seeing more people turn to AI to serve as therapists for them in essence. And that's scary to me, because, there is not those micro skills. There isn't that human connection. There's no one to really give you that eye contact and say, tell me more what you're thinking about. So it like you said, it is really guided to what you put in there. And so I definitely want to grow in that effort to train our students correctly. I'm sorry, I saw someone put a comment in the webinar chat, and I wasn't sure if we answered those or not, about will HIPAA be compromised? So
Go ahead. Yeah.
That part I'm not sure, so I'll turn it over to the doctors to answer. Is HIPAA compromised by AI technology?
I think the HIPAA law applies, but it can be implemented in a way that's compatible with HIPAA. You could certainly implement it in a way that's not compatible with HIPAA, but I don't think that's probably the big challenge right now. I'd just say, and I don't know, Terry, if you want to move on to other questions, but I'm open to the idea that AI could be meaningfully helpful, and here's why. I think there are a lot of people. Our healthcare system has so many problems from the patient's perspective. It can be very frustrating to even get simple things done. And so if there are a couple scenarios where I could really imagine it being useful, even in a more clinical way. But if you have to go all the way into the doctor and it's very cumbersome to do that, and there's an option to first of all pay a lot less, have a zero wait time, and get something that you need very quickly, you can still, under the cover of your overall relationship with the doctor or nurse, it may be worth it. I do think that it's really important to research those kinds of uses to see how it goes. And I do think it could really make life better both for patients and doctors. You could imagine it working. So I think there's a lot yet to learn about the correct use of AI, recognizing that there are incorrect uses of AI that we have to be on the lookout for too.
That's great. I'll transition at that point, but it does remind me of the conversation we had earlier today with Isaias about the accountability of these AI tools and who is left being accountable, right? So the difference between the human in the loop or the doctor in the loop, as we are talking about right now in your cases versus somebody just using Chat GPT or something like that as in replacement of a therapist, right? There is no accountable person on the other side. Like if you get your notes wrong, like I gave an example earlier of my boyfriend's mother, went into an appointment. They used an AI note taker. Her husband is chatty and talked a lot about himself in that meeting. And then the notes came back basically with his history and not her history, so there is an accountable person there, right? Like that note taker should have edited for those issues. But when we
And
talk
and
about,
and and just to
yeah.
say that like the therapy issue is deadly serious. I have the School of Public Health has a podcast called Public Health on Call, and I interviewed the mother of a young woman who actually killed herself. And 6 months after that happened, the friend said to the mother, and this is all in the podcast, did you look at the chatbot? And she said, what do you mean? And they found hundreds of pages of going back and forth with the chatbot. This was not actually an example of the chatbot saying, telling the young woman to hurt herself, but it was an example of the chatbot kind of just expressing empathy and not really helping. It was like, I feel hopeless. It's like, I'm so sorry you feel that way. But it was, I'm planning to hurt myself. I'm so sorry you feel that way, rather than, hey, you got to do something. You got to tell someone. You got to let's figure out what to do. So like using at this point those chatbots is dangerous for that purpose. And is it possible there could be a role for AI chatbots? Again, even the mom of this young woman thought the answer to that was yes, but she definitely thought there needed to be a lot more research and safeguards before that really could be recommended.
Yeah, something else I would like to add to your response is that in the role of chatbots, if some of us have been thinking about it, like say for example, um, potential patients or clients are interacting with chatbots. Is it possible to have the chatbot trigger feedback with actual clinicians to intervene when the situation is becoming too uh if the chatbot is not able to express more than empathy and the situation keeps coming up repeatedly, is it possible for it to trigger a feedback loop to an actual clinician who can follow up from whatever is in the chatbot? So these are like so we're still going to get to that part about the training gap, but uh these are some of the feedbacks that enhance healthcare and how artificial intelligence is being used in clinical setting. And that would be my addition there.
Like a triage situation almost. Yes. Love it. Okay, next question. Good. Building AI literacy in a healthcare workforce is easier said than done. What is the single biggest barrier you see to training health professionals to work effectively alongside AI tools? And what strategies have you seen actually work? I'm going to kick this off with Obi, and then go with Dr. Poole Sykes after that.
So, hi, thank you. So on my own end, I think one of the biggest barriers is access to artificial AI tools or even the technical skills, like because there's a high instance of it being misunderstood in terms of what the bot is doing, what the AI is doing, or what it isn't doing, the breadth of intervention that you can utilize it for. So what I've noticed recently is that many healthcare professionals falls into two extremes, right? They either overtrust, put too much faith in what the AI output presents or completely distrusts them. And in that case, both situations, both spectrums are actually quite risky. Now, a practical example is sometimes when AI is being used in documenting as a documentation tool. So some clinicians, they assume that the output is always accurate and they don't review it critically. And which also spoke to the previous last comment about being able to utilize the tool and follow up with the tool. So while some other people, they totally avoid using the tool entirely because they don't trust the tool. So in terms of effectively using the tool, it sits somewhere in the middle. We need to understand the limitations of the system and actively validate what it produces, right? So many challenges across the tool, because just like the last presenter before this session, she talked about the internet boom and how our parents reacted to it. So same way, artificial intelligence and how people are reacting to it. How can we consistently encourage people to improve their skill sets around these tools? And there's so much more. In fact, from a workforce development perspective, right? Let me just add this here. From a workforce development perspective, right? I think most training has shifted away from simply teaching the tool, use of the tool, and they now focus on how do we evaluate AI outputs critically? How do we recognize that there are bias and the limitations of bias? How do we understand the ethical and governance implications, right? So most importantly, how can we integrate AI insights into real clinical outputs and make it responsible? But it's not just training healthcare professionals to use AI. We are training them to collaborate with AI. And that, for me, from my perspective, should be the goal. Because we need to build a mindset, especially for emerging professionals, as what will make AI integration more responsible, more effective, and human-centered for future healthcare workforce. Okay. So.
Well, let's see, Dr. Poole Sykes.
Yes, that was awesome, Obi. I wholeheartedly agree with everything that you said. I think the biggest barrier is what's going to happen in a few more years when counselors are no longer critically thinking. We've sort of missed this boat where using AI creates such a leisurely way of getting information, but that information may or may not be accurate, may or may not be an authentic voice. And how does it help our profession? And thinking about those barriers and knowing that critically thinking will be a huge deficit, it's sort of scary. It is absolutely scary. I think last week I talked a little bit about what we're doing to close that gap within the educational platform. We've gone back to Scantrons. We are now encouraging our students to take a test using what we used back in the 70s, a Scantron machine. So what that also means is we have to explain to our students what this thing is and how it is scored and why they have to study versus how they used to do things. So bringing in old school methods may be one way of ensuring that our students are critically learning versus rote memory.
You're giving me some pretty intense flashbacks to Scantron machines. Just to tell you, and people may not know this, but you'd get a little thing, you bubble it in a number 2 pencil, and then in my class, I can almost picture the layout of the class. they would line us all up and we'd have to run our own cards through the Scantron. And every time it marked one wrong, you'd hear beep.
Yeah.
So like some people would go through and you'd hear no beeps and they got a perfect score. And some people was like beep, 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 beep. And you'd be like, oh, that was stressful. Hopefully the people won't do that. You could
No, you don't
grade
do it
them
that
not
way.
in front of all the students,
No, it's not in front of all the students.
Yeah, that was very traumatizing for me, I think, in retrospect, now that I think about it. But I do think the question is a good one. How do we teach people to use AI effectively? And I think it involves critical thinking skills. It's not just here's a tool, here's how you use the tool, but what's the purpose of AI? How do we want it to work? And what's the evidence that it can help us in particular reason? Why, if an AI tool is being used, what's the thinking behind it? It should be explained, I think, to students, and then students can reflect on whether or not it's actually achieving the goal. The purpose here is to help you be able to have more human time, more one-on-one time with the patient. Well, is it working? What's the feedback? So rather than thinking of it as something to be imposed, in the clinical setting, something that people can be learning about and providing feedback on as it goes.
Dr. Swen, I'd love to hear what you have to say from a public health perspective.
I mean, I go back to again, I think where, I think it's tough because I think there's so much there's so much burden on the healthcare system, right? And so again, I go back to this idea that you're always going to default to kind of the thing that is in front of you, and that potentially is easier because of the cognitive overload that you have, right? So it's similar to like Nigam Shah kind of describes it as like, it's not that things are good right now with AI. It's more that people are really like you're starving, and there's like, whatever your favorite, there's a donut there, and you eat it because you're so hungry, and there's no willpower whatsoever. It doesn't even matter anymore. So I like that saying because I feel like that's what it is. But I just keep posing kind of that question of like, I like what was said about from like an informatics side, which is what I, do as well. And from the diagnostic side, I think that's very interesting from the analytics side. So I'm more open to that, but I do not think that technology should be in any sort of human interaction whatsoever. And I think we do need to go back into kind of old school training methods, maybe not the Scantron where it's public shaming I saw in the comments, which was terrible. But I pose a question to everyone is like, where did technology in terms of community interaction make things better? I mean, airlines, like, when you call for any customer service anywhere and you get, it's not AI, but you get a bot, beforehand, or you get a recording service. I mean, how horrible is that? And so, or you go to the grocery store, right, and you do a self-checkout and something doesn't work and so forth. But also, when has technology made things like we talk about AI making things more efficient, and more cost effective, but like I don't see in any industry that anything getting cheaper. I mean, obviously control for economic factors and so forth, but I have not yet seen that be the case. Like similar to kind of the EHR, right? It ended up being more work. Like, is it easier to take notes yourself, or the accountability is there, which is important, but then there's 10 pages of notes that you now have to review because it's so thorough versus taking the notes yourself. And maybe it being very clear and consistent and concise.
Yeah, now we're becoming editors rather than, which is a very different skill set, right? So, well, I appreciate the perspectives here. Very good. Let's move on to maintaining. It's perfect. How do we maintain the human in healthcare? As AI takes on a more clinical and administrative tasks, as we've talked about today, how do we ensure that empathy, ethics, human judgment remain at the center of care? I think we've kind of alluded to it today. Maybe these tasks can free us up for more human interaction. But what does responsible AI integration actually look like? Both at the practical level and the leadership level. We'll start with Dr. Sharfstein.
Well, I think that's a question a lot of people are grappling with. I'm not sure everybody exactly knows the answer, but there are really important ways to teach the human side of medicine and healthcare in general. Where people really listen to patients. I remember in my training in medical school, we spent really almost like a whole year just asking questions of patients and trying to understand what it was like to have different kinds of diseases. And then there are other interesting ways. I learned today about a new program that uses the arts, different plays, murals, movies, music, other things to help people realize that they're in the business of healing, not just like a different kind of auto mechanic, you know? And so really making sure we can keep investing and invest more in those kinds of types of training is just really important to emphasize what this is about. Hopefully, like we said, AI gives more time for that. But I think it's really important. And in my training, I always felt that my patients were the best teachers. And I learned to, be incredibly respectful of them, their parents, obviously. And there are really difficult times in training. As a pediatrician, I've seen some very, very sad things. And, that human side isn't just important for how you take care of patients, but it's very important for how you take care of yourself. And if you forget that, you can find yourself in a really difficult position when you're a witness to very serious problems happening.
Lakeisha.
Yeah. And Dr. Sharfstein, you just said exactly what I was thinking. Taking care of yourself is the one of the most important parts of this. I know Dr. Poole-Sykes and I have this conversation all of the time. And even though I'm not directly working as a clinician, working in higher education, training clinicians, um, I know firsthand from when I was doing that type of work to the type of work I'm doing now, self-care is important and how AI can definitely help with that burnout that we often get as being providers. And so I definitely am an advocate of it. Here at on a university level, we are coming together in teams to determine how best to infuse AI into higher education and the work that we're doing with our students and staff and faculty and things such as that. But I'm also very concerned about the ethical parts of it. And I think that's when we talk about in leadership, ethics will always reign supreme to make sure that we are being ethically sound. And this is something I preach to students. I remember when I was a doctoral student many, many years ago, how when I was doing qualitative research, I was cutting up pieces of paper and identifying themes. It's a pleasure for me now as a dean of grad school to see students using AI to do those type of tasks much, much faster. But also I want to know, are you truly understanding what the people you're interviewing, what they're saying, and this translates into when they actually go out into the world to perform those tasks with clients. So I would say, just to sum it up, ethics and self-care are something I'm always going to be looking at as a leader. And I think Dr. Sharfstein, someone had a comment for you in the chat.
Oh, somebody wants to learn more about the arts training that you mentioned earlier, the arts to help in medical healing.
Yeah, I'll see if I can put some parts of this into the chat while we're talking. I actually just learned about it today, so I'm not an expert in it, but seemed so relevant, and I was just hearing about it.
That's awesome. Isaias had a question for Obi. Comment about potential intervention being triggered when potential harm is detected, duty of care versus clinical boundaries, privacy versus surveillance, balancing AI privacy rights against mandatory safety reporting duties. Do you have a comment in there?
Could you go back on the comment?
Mhm.
I'm reading it.
Isaias is here. He could maybe come off mute.
Yes, please, Isaias.
Unless we lost him.
Oh.
Oh, he might not be a panelist. Oh, yeah.
He's here. He's trying to, hold on, Isaias, would you mind raising your hand so I can give you access to unmute? Okay, give me one brief moment here.
Sorry about that.
Okay, you should have access now.
All right.
We heard you.
You can hear me?
Oh, we did.
Okay, I'm here. Okay, thank you. So that comment about potentially triggering intervention raises probably the balance between mandatory reporting duty.
Hey, Isaias, I think some people, they're having a hard time hearing you. Can you try what? Are you trying coming over here? Okay. Okay, go ahead.
All right, can you all hear me now?
Yes.
Hi, good. So the comment triggered for me the tension between the promise that AI companies promise that the chat logs are private on the one hand, and then the duty of care mandatory reporting that when the AI triggers a potential intervention. You might have seen the recent Florida Attorney General opening criminal investigations into OpenAI because someone used ChatGPT to plan a mass shooting in a Florida university last year. So that's going to be a really important tension between privacy of the patient, not even a patient, but in your privacy, you're going through chats on either using cloud or whatever is available, and then the fear of surveillance, or at the same time, do you want the AI to be a silent witness to tragedy?
So, from my understanding so far, the developers of these tools, they are working. So they first things first, they design each tool for the user. So yes, HIPAA has to be paid attention to in clinical. Then over time, even as a student researcher, we are told that yes, when you're using the subscription model, your data is not leaked. However, the universe has access to your data. And because the universe has access to your data, yes, it may not be evidently leaked out or utilized, but my own thought process around, and I'll speak for myself, so my own thought process around that unique space is that which also spoke to the use of the potential, my thought around the potential use of the chatbot. If there are triggers, there are recurring triggers from this particular user, is it not possible to investigate? Because yes, Dr. Shafsny, you want to say something? Oh, so I saw you nod. So, so my thought around, I hope I'm addressing the question. Isaias?
I think so.
Yeah,
Okay.
you're addressing the question, and it's an open question, and the Florida case is only at the investigation stage. There has not been any formal criminal charges.
I would even go into I would check the case because I know of late some days ago we were in a meeting with Google and we're asking some questions around how they use the information, access to the information, what are the back end there's a word I'm looking for, but more like guardrails. So what are the back end guardrails you're putting in place? Because it's an entire universe. And if, for example, something is happening on one end, are we not monitoring? Are we not paying attention? Are we not checking? But then in terms of clinical practice, it's my understanding that the models designed for, say the model designed for myself as a student researcher in school is different from the model designed for, say, for example, the EHR, the systems that just check like your blood pressures and records your numbers and feeds it to the computer for access. In fact, I had an interesting situation when I had an accident and my blood pressure is on the lower end. I'm hypotensive and my blood pressure spiked and the machine picked it and just changed the color. and it was something that the doctors were able to pick up almost immediately. That's a good part of using it. But how, so, so for me, it's more like this is an emerging space. And the encouragement is, since this is the reality of today, we need to start being trained, being aware, because it's again, garbage in, garbage out. It's dependent on what the system is being fed.
Thank you very much. Just whether these companies have a vision into what we type on ChatGPT, they do have that because OpenAI voluntarily submitted the chat logs to the Florida Attorney General. So even when they say your interactions are private, they're still monitoring it.
Thank you for that, Isaias.
Okay, we have about 5 minutes left. This has been a really robust conversation. I think we could probably have it all day long. But I think we'll just end with a lightning round question. Thank you, panelists, for answering questions in the chat. Feel free to continue to interact in the chat. I'm going to kick this off with Dr. Swen. And then we'll go around, just kind of round robin. What is one AI tool or application in healthcare that excites you right now? If there's any.
AI for image analysis. So for any type of multimodal kind of image analysis and the integration of like all of text, audio, visual kind of data. That's what really excites me.
Lakeisha?
Yeah, I would say chat boxes. That's what I'm getting into right now. Being able to have access readily on a website, being able to type in data, especially with the projects I'm working on now, with providing more access to individuals in rural areas who need support.
Dr. Poole Sykes.
I agree with Dr. Harris in terms of those chat boxes. That's sort of what we're doing at a very preliminary stage. Working within the counselor ed field, we are embracing a whole new way of thinking by integrating some of these AI technologies into what we're doing. So right now, this chat box has been an eye opener in terms of some of the preliminary basic psychoeducational material we are able to provide quickly. So that this has been really interesting, watching how the chat box and use of it to impart education has become important for us.
Thank you. Obi? Obi, do you have one? Oh, sorry, go ahead. Do you know the question?
My system got stuck. So for me, it's the integrated development environment. Why? Because that has significantly helped or supported AI in bioinformatics. And for me, my main interest still leaning towards precision medicine. So particularly in areas like gene expression and transcriptomic and analysis, RNA sequencing. So here, AI has helped us analyze extremely large biomedical data sets, and it makes the process more efficient, and you can identify patterns much more quickly and start working on interventions. So for me, the most exciting part about this is not just that, yeah, I know the concern that AI could replace humans, but I believe it's expanding our ability to make more informed, personalized, and efficient decisions while we can use it. And I think we need to be more convinced in our capacity because if we have that confidence, we'll be able to interact with it, question the process, question the outcome, and ultimately, our results will be outstanding.
Thank you very much. Dr. Sharpstein, you want to wrap us up?
It's been such an interesting discussion. You know, I certainly think there's certain things where AI has proven its value, including in imaging analysis, including in drug development. And there are a lot of areas of promise. And it's important to consider them and to study them. And I'm open to all kinds of interesting applications of AI, but just because something is AI doesn't mean we automatically think it's a good idea. So, it has to prove itself like everything else. I think that there's a lot of potential to help clinicians with the work that they do and to help patients get more access to care.
Wonderful. Great conversation today. I appreciate every one of you so much. We'll continue our conversations as the afternoon goes on, but hopefully we have a chance to connect again. Thank you so much.
Thank you.
Nerys, I'll give it back to you.
Awesome. Thank you so much, everyone. We really appreciate this discussion and all the insightful questions that we also received in the chat. We appreciate that because they were very engaging. So thank you again to our panelists and our panel moderator for a wonderful session. This was very insightful and engaging, and I'm sure it provided a lot of value to our audience. Now we're going to take our last break of the afternoon before we get to our last special guest presentations and then our final remarks at the end of the conference. We've got more great content ahead, and if you have to leave, please feel free to scan the QR code and complete our brief survey. We really would appreciate your feedback. I will see you all back at 3 p.m. All right, we're about 1 minute away from 3 p.m., so I will go ahead and begin with our introductions. So welcome back from break, and we're now going to begin our final and very special set of presentations for the day. We're excited to continue the conversation with a panel of UMD School of Public Health undergraduate students who will be presenting their Global Digital Health in Action capstone innovation projects. Leading this session is Dr. Hassanatu Blake. Dr. Blake is an associate clinical professor and the inaugural director of the Global Health undergraduate program in the Department of Global, Environmental, and Occupational Health at the University of Maryland School of Public Health. With over 20 years of experience as a global health leader, her expertise spans health equity, digital health, prevention, social and structural determinants of health, and health systems and program management. Dr. Blake bridges research, policy, and practice to advance innovative solutions for marginalized populations globally, while preparing the next generation of public health professionals to shape the future of global health. Today's presentations will be delivered by 3 global health majors from the University of Maryland: Omolola Adebegmeleke, Bertil Ingrid Deko, and Varsha Irapogla. These presenters are all senior undergraduate students, so please join me in congratulating them on this exciting new milestone. Thank you all for being here today and taking the time to present your capstone projects. The floor is yours, Dr. Blake.
Thank you, thank you, thank you. It is such an honor and a privilege to facilitate this session today, because this is a showcase really of our students and the future that will take shape in the hands of the next generation of global health leaders. So before we get started, I would like to first share my screen. And okay. And okay. Can everyone see my screen?
Yes.
Okay, perfect. So before we get started, I wanted to ground us with why this moment is really important. At the School of Public Health, we believe that global health is everywhere. It's local, it's international, and it's virtual. So global health lives in data, it lives in policies, it lives in our communities. So our students in our inaugural Global Health Capstone course were challenged to take this new approach to global health and apply it to the digital world that is increasingly reshaping how we see our health and our lives. They were asked to think critically, act ethically, and also center equity in the communities that they would be exploring or studying. So in just a moment, you will hear from 3 remarkable scholars who have done exactly that. They will have 10 minutes to present their projects, and then followed by a 5-minute Q&A. All right. So our first speaker or presenter is Lola. She's a senior majoring in global health and is preparing to actually be our first graduate of the global health major in just a couple of weeks. Lola will present her capstone that explores antimicrobial resistance in industrial animal agriculture. She examines the policy gap between what AI and machine learning surveillance tools can do and what current governance frameworks actually require. This is a really important policy relevant scholarship that I'm really excited that is on today's stage. So I'll hand it over to Lola for us to get started. The floor is yours. Let me stop sharing.
Okay, so my capstone is machine learning for antibiotic resistance monitoring, and I explore the policy gap in industrial animal agriculture. So just for a brief overview, so CAFOs are concentrated animal feeding operations, and they're large-scale industrial livestock operations that confine large amounts of animals in high-density environments. And these operations are important because although there have been regulations on the use of medically important antibiotics for growth promotion, these operations still rely on antibiotics to prevent and treat disease. And this contributes to the development of antimicrobial resistance within the sector. And AMR occurs when bacteria evolve resistance to antibiotics, making infections more difficult to treat in both humans and in animals. At the same time, artificial intelligence and machine learning are increasingly being explored as tools for AMR surveillance and monitoring. And why this matters, so this issue matters because CAFOs create conditions that increase disease transmission among animals, leading to frequent antibiotic use. And in the United States, around 70% of medically important antibiotics are sold for use in animals. And resistance doesn't just remain isolated within the farms. Resistant bacteria and antibiotic residues can spread through food systems, environmental contamination, water runoff, and waste. And because of this, surveillance systems are definitely important for identifying and monitoring resistance and trends across human, animal, and environmental sectors. And onto equity and environmental justice concerns. So, an important part of this issue is that CAFOs are disproportionately located within low-income rural communities and communities of color. And residents living near these operations may experience exposure to contaminated water, manure runoff, air pollution, and waste disposal sites. An example of this is in Duplin County, North Carolina. And these patterns show that burdens associated with industrial animal agriculture are not evenly distributed. And because of this, surveillance systems may fail to capture local environmental and health impacts. And then onto AI and machine learning. So machine learning has growing potential within AMR surveillance. These tools, which are a subset of AI, are being used to detect resistance trends, classify microbial patterns, link environmental and microbial data, and predict the emergence of resistance. And one example comes from Baker and his colleagues in 2023, who used machine learning and metagenomics in chicken farms in China to identify shared resistance genes across farms and environments. And additionally, another study by Benifo and his colleagues in 2024 used genome-based machine learning models to predict salmonella resistance with over 95% accuracy. And although these studies show promise for AMR detection while using machine learning models, there are some important limitations, such as the fact that most machine learning models for AMR have been developed in clinical settings rather than in industrial animal agricultural settings. And there's also concerns about limited data diversity, environmental data gaps, and algorithmic bias, which can all unequally affect the results of the study. And for the current policy landscapes, so the first policy is the CARB National Action Plan, which is the national strategy for combating antibiotic-resistant bacteria. And this strategy uses a One Health framework and focuses on surveillance, reducing unnecessary antibiotic use, and improving coordination across sectors. And the second one is NARMS, which is the National Antimicrobial Resistance Monitoring System. And it's a collaboration between the CDC, the FDA, and the USDA. And it tracks resistance in foodborne bacteria, retail meats, and livestock. And importantly, NARMS has started discussing advanced analytics and machine learning as future surveillance tools. And the last framework is the National Institute of Standards and Technology AI Risk Management Framework, which focuses on responsible AI development, risk management, and oversight, and it's a voluntary framework. For the policy gap, so although these frameworks address AMR and AI separately, several important gaps remain. So firstly, CARB addresses AMR broadly, but does not specifically govern how AI and machine learning should be used in livestock surveillance systems. And NARMS is beginning to explore advanced analytics, but these technologies are treated as still emerging rather than fully integrated systems. And then the NIST framework provides guidance for AI governance, but it does not include agriculture or One Health specific standards. So there is limited guidance on how surveillance systems should address environmental exposure pathways and the disproportionate impact on communities located near CAFOs. And for the policy recommendations, so to address these gaps, my capstone proposes several policy recommendations, which the first one would include integrating AI into national AMR surveillance systems like NARMS and the CARD plan, which would standardize guidance for how these technologies are developed, evaluated, and implemented. And then second would be support for community-based environmental monitoring near these CAFOs should be expanded. So this would improve the detection of localized AMR risk and help ensure that vulnerable communities are represented within surveillance systems to not only expand the data, but to get more accurate results. And then the United States should also develop a national coordinated AI governance framework for AMR surveillance, which would help reduce fragmentation across human health, animal health, and environmental monitoring systems. And in conclusion, AMR in industrial and agriculture is a really big One Health challenge with implications for human health, animal health, and environmental health. And AI and machine learning have really strong potential to improve AMR surveillance, but their use within industrial animal agriculture is still emerging. Current policy frameworks remain fragmented across AMR governance and AI governance systems. And as a result, important gaps remain in integration, standardization, and equity. And moving forward, more coordinated One Health governance would be needed to ensure that AI and AMR surveillance systems are effective and equitable.
All right. Thank you, Lola. Really appreciate this. Great presentation. Right now, we would like to take any questions that the audience may have for Lola. We have 5 minutes. So if you have any questions, place your questions in the chat or raise your hand. I don't know if you can come off mute. If you can, we can identify you and pull you up so you can ask your question. Katya, thank you for your question. I'm just going to read what you shared. Great job on your capstone, Lola. I can't imagine pulling off something like this and then presenting at a conference when I'm getting my MPH. Did you interact with any community groups battling CFOs from an environmental justice perspective? And can you work on the groan of AMR assist with giving more arguments for shutting down or reducing the number of CFOs? And she meant growth. So let me rephrase that. Can you work on the growth of AMR with giving more arguments for shutting down or reducing the number of CFOs?
Yeah, so thank you for your question. I'll start with the first question about interacting with community groups battling CAFOs from an environmental justice perspective. So I'm actually in a fellowship, which is called the Reducitarian Fellowship, and we hear from a lot of speakers about people who've lived near CAFOs and also workers who've worked inside these industrial operations. And we heard from a farmer, and his perspective was very interesting from an environmental justice perspective. He kind of gave us insight into how things work and how very limited authority that they have within these farms to control the feed for the animals and the whole production for the whole thing. So that was really interesting. And then hearing from communities located near the farms as well, hearing about the health issues that they've experienced associated with living nearby, such as a lot of like upper respiratory issues and things such as that nature. So interacting with those groups kind of provided a lot of insight as to how big the problem really is. And you said, can your work on the growth of AMR assist with more arguments for shutting down or reducing the number of CAFOs? And I think that it definitely can. The rise of AMR is a global problem, and I think it's bringing more highlight to the CAFO industry and their antibiotic use. And even though it's been more regulated with less antibiotics for growth promotion, but antibiotics are still being used to treat and prevent disease in these animals, which does lead to resistance in some cases. So I think there is a big argument there for either lessening the amount of antibiotics or increasing monitoring and surveillance systems within the farms.
Excellent. Thank you, Lola, for your presentation. We really appreciate it. We're going to move on to our second presenter. Our second presenter is Bertil Ingrid Dago. She is a global health major graduating this fall. Ingrid capstone is a comparative analysis where she examines how digital maternal health tools function for low-income women in Baltimore, Maryland, and also Abidjan, Côte d'Ivoire. Her work asks, do digital tools designed to improve maternal health actually reach the women who need them the most? And her project is also a reminder to us that global health lives in every zip code, especially those that are in zip codes where structural barriers really shape who gets care and who doesn't. So I'm going to hand it over to Ingrid to share her screen and share her project.
Okay. Can you see my screen? Okay. So this presentation, okay, yes. So hi. So this presentation will look at how digital tools are supposed to help pregnant women. To understand why this matters, let's start with the global picture. Maternal health has improved over time, but major inequalities remain. In 2020, about 287,000 women died from pregnancy-related causes, and 70% of those deaths were in sub-Saharan Africa. Importantly, low-income women face higher risk everywhere, even in wealthy countries like the United States. These differences aren't about individual behavior, they reflect access to care, social conditions, and how health systems are structured. So what exactly is the problem we're trying to solve? Many women face barriers that make it hard to get maternal care. These include high out-of-pocket costs, difficulty reaching providers, transportation challenges, limited health literacy, and unreliable health systems. Digital tools like apps, telehealth, and text reminders are meant to help that, but they don't always work the same for everyone, especially for low-income women. So, how do digital maternal health tools work for low-income women in different healthcare systems? To answer this, I compared two cities with very different contexts, Baltimore and Abidjan. But before looking at the findings, here's how I approached the research. I conducted a comparative literature review using data from 2014 and 2024. I used sources like the World Health Organization, the CDC, UNICEF, the World Bank, and peer-reviewed studies. I focused on studies about maternal health, digital health, and inequities in urban low-income populations. I also analyzed 4 themes: health system structure, access to care, digital tool use, and barriers to implementation. Baltimore has advanced hospitals, but deep inequities. Maryland's maternal mortality rate is about 24.8 deaths per 100,000 births, and Black women are 3.7 times more likely to die from pregnancy-related causes than white women. Barriers include insurance complexity, fragmented care, provider shortages in low-income neighborhoods, and chronic stress from racism. Digital tools used include telehealth, remote monitoring, and patient portals. In comparison, Abidjan faces cost-driven and infrastructure-driven barriers. Maternal mortality is much higher, about 617 deaths per 100,000 births. Only 45% of women complete 4 or more antenatal visits, and smartphone access among women is around 34%. Digital tools include SMS, reminders, mobile health education, and NGO-supported programs. With that context, let's move into the key findings. So my analysis focuses on 3 major issues: design issues, which are tools often don't match real life needs; system barriers, tools can identify risk but don't always guarantee care; and digital access, not everyone has the devices or the skills to use the tools. Let's start with the design issues. Many digital tools are designed for people with stable internet, personal devices, and high literacy, but that's not the reality for many low-income women. In Baltimore, patient portals and apps assume broadband access and comfort with medical language, and versus in Abidjan, only about 34% of women have smartphones at all, and so app-based tools miss most women. Tools also often ignore language needs or cultural context. And when those tools don't match real life conditions, the people who need them the most are the least likely to benefit from them. And next, we can take a look at the system barriers. Digital tools can flag risk, but they can't fix weak or unequal systems. In Baltimore, remote monitoring may detect high blood pressure, but insurance rules, provider shortages, and long wait times delay treatment. And in Abidjan, SMS reminders encourage women to seek care, but clinic fees, long distances, and understaffed facilities still prevent access. So even when women want to act on digital information, the system may not support them. Now let's talk about digital access. Digital tools only work if women can actually use them. In Baltimore, some neighborhoods lack broadband and devices are often shared. And in Abidjan, smartphone access is low and data plans are expensive, which means that digital tools often reach women who already have better access and miss those with the highest risk. So over here, we have a comparison between these 2 cities. Even though Baltimore and Abidjan are very different, the patterns are surprisingly similar. Baltimore's main barrier is insurance complexity. For Abidjan, it's cost and infrastructure. Both cities use different digital tools, but both struggle with follow-up and access. And in both places, access to care, not technology, is the strongest predictor of outcomes. And this shows that technology alone cannot overcome structural inequities. Maternal health outcomes are shaped by access to care, system strength, living conditions, and digital access. Digital tools can help, but only when the systems around them are strong and equitable. Across both places, digital tools should be designed with low-income women, not just for them. Tools must be connected to real care pathways, and programs should measure equity, not just usage. And most importantly, investment must start in health system, not just the apps. In conclusion, digital maternal health tools have real potential, but they cannot fix unequal systems on their own. Baltimore and Abidjan show that access to care, system strength, and digital access matter far more than the technology itself. And there's one more important point, and it's that maternal health is not shaped only by medical care. It is influenced by the environments women live in, the conditions around them, and the systems that connect people, communities, and resources. Both cities factors in like transportation, neighborhood, infrastructure, stress from unsafe or unable living conditions, and access to reliable technology all directly affect whether digital tools can actually help. So for digital tools to truly improve maternal health, we have to strengthen not just healthcare, but the broader conditions that support women's well-being.
Thank you, Ingrid. Great presentation.
Thank you.
Any questions for Ingrid? And again, you can place your questions in the chat or raise your hand and we can identify you and come off mute. I have one question, Ingrid. It was great that you were able to provide some recommendations in the conclusions about the connection between digital tools and healthcare systems. I wanted to know, what does that look like in practice, particularly when we're thinking about cities like Baltimore or a city like Abidjan, which you stated have some similarities when it comes to this. Where, how does that look in those cities? And given all of the fragmentation that you see in both cities, how could some of those recommendations manifest itself? You're on mute, Ingrid.
Okay. So how does that look so in practice, it looks different in each city. But I guess the outcome can still be similar. Like, for example, in Baltimore, a woman might technically have access to digital health, the healthcare and digital tools like telehealth or remote, the apps, but she may still struggle to get actual care because of insurance and the long wait time. So even if a tool identifies a health risk, the treatment can still be delayed. So, and like I said, in Abidjan, the barriers are more related to cost and infrastructure. So in both cities, technology can help with communication and awareness, but the healthcare system and living conditions around the patient is the final determinant of whether the tool can actually improve the outcome. If that answers this question.
It does. We have another question in the chat from Dr. B. She said she is curious what you thought about the quality of research and data. How recent were the studies from both locations?
Well, I guess actually I feel like that was one of the challenges of my project, actually. The quality and amount of research were much stronger for Baltimore. There was much more data for Baltimore compared to Abidjan and Côte d'Ivoire. For Baltimore, there was a lot of recent data available from the CDC and the peer-reviewed journals. And there was also more studies specifically focused on racial disparities. But for Côte d'Ivoire, the research was more limited, especially when looking at like digital maternal health tools. And a lot of the information came from broader global health reports and NGO reports and regional studies. So some of the studies were also like really old because there was just not as much published literature available. So I guess one takeaway from the research was actually noticing the gap itself. And there's much more data and funding focused on maternal health and higher income settings, while in the low income places, they have less documented research available.
We have one last question before we move on to the next presenter. We have, what are your suggestions for technology in lower income communities? Think about devices to bridge the gap for better healthcare.
Sorry, I was muted. So one suggestion would probably be designing technology around the actual realities of low income communities instead of like assuming that everyone has constant internet access and newer smartphones or high digital literacy. So for low income communities, like SMS reminders or low data mobile platforms is probably more effective than like the advanced apps that need strong internet connections. And I think community-based support is also really important. And I think technology will work better if it's connected to like existing healthcare workers, clinics, and programs instead of like functioning on its own.
All right. Thank you, Ingrid. Great presentation.
Thank you.
If I haven't gotten to your question, I'll try to get back to it, but I want to present our third and final presenter, Varsha. She is a global health undergraduate student graduating in the summer of 2026. And Varsha's capstone brings us to India, right? And this is where there is persistent maternal mortality in urban slum communities. And this is due to barriers that could be attributed to poverty, provider shortages, and also limited digital literacy. Varsha will share with us her proposed AI-based maternal health support intervention design that integrates community health. I would like to thank all of you for joining and supporting the presentations of our students. And I am going to hand it right back over to Nerisse.
Awesome. Well, great job, everyone. You guys did a fantastic job with your presentations and your capstone innovations. Again, congratulations on your new milestone, and we wish you the best of luck. You guys are a great representation of the University of Maryland. So again, thank you, Dr. Blake, and our inspiring undergraduate students who represent the next generation of leaders working to advance global health and making a meaningful impact worldwide. To close today's conference, we are happy to welcome Dr. Jin-Hee Kim for final remarks regarding the advances in AI and health at the University of Maryland. Dr. Jin-Hee Kim is a professor in the Department of Family Sciences at the University of Maryland School of Public Health and serves as Associate Dean and Associate Director at University of Maryland Extension, where she leads the Digital Literacy Project and Family Consumer Sciences programming. Her work focuses on financial well-being, economic stability, and health with a strong emphasis on community impacts. She has led numerous initiatives in areas such as mental health, substance use, financial literacy, and rural health, and is a nationally recognized leader in financial education as well. Dr. Kim's work continues to advance research-driven programs that strengthen individual and family well-being across Maryland and beyond. And we thank you here for making the time with being here with us today, Dr. Kim. Please welcome Dr. Kim.
All right, thank you, Nerisse, for the kind introductions. Good afternoon, everyone. My name is Jin-Hee Kim. I'm Associate Dean and Associate Director for University.
Hi, Dr. Kim. It seems like your video has stopped. Can you hear us? I think there may be some issues with internet connection. If you all could kindly give me one brief moment while I connect with Dr. Kim. And in the meantime, if you all have any additional questions that you'd like to add for our speakers, please feel free to go ahead and add that in the chat as our speakers continue to answer those questions. Okay, Dr. Kim is back. Let me rename her very quickly. There we go. Hi, Dr. Kim, can you hear us?
Yes, can you hear me?
Yes.
Okay, I feel I'm in the digital divide today because somehow I'm in the office on campus, but I lost internet. So I'm joining with my phone, so apologize. I apologize for the inconvenience, but I'm so thrilled to welcome you. And then, I am so glad to hear that you enjoyed the conference and active conversation discussions and to move along these technology to advance the health and well-being of our communities. So University of Maryland Extension has been around since 1914, and our role is to translate the science and really bringing the technology to the people in their hands. Those people include the youth, older adults, people with disabilities, people with different types of limitations or underserved and underrepresented. Our program has been open to all. But public health and technology issue is really dear to our heart. We are leading in the efforts in nutrition education. And so UMD and University of Maryland Extension is really trying to bring health technology to advance nutrition and health of the people, those people who need the most. And those lessons we learned and practices will make a differences locally and also globally. And our strength is we are rooted deeply into the communities. We are in 23 counties and Baltimore City office. For example of the Marylanders Online, we have partnerships, over 265 partnerships, locally, state level, and national level. But we're bringing the university to the communities. So I am so excited to hear my colleagues from different colleges, including the AGNR and the School of Public Health, and then other institutions in Maryland to really support the communities through access and an understanding to advance their health. And we're always are supporting the research, emerging research, and future directions. So AI is the currently really important technology that we want to invite our people, emerging areas such as AI-enabled health systems, digital equity, and those scalable models for technology integrations in the care delivery. But we also want to make a difference connecting those practices and the future research to enhance the research, but also making a differences in the communities with the scalable, sustainable, also readily available, applicable to the communities' very issues that our people are experiencing. So I really want to thank all of you and congratulate all of you, Neris and Isaias and Planning Committee for bringing this excellent opportunity to address emerging health conference, integrating AI and other technologies. So I want to thank all of you and congratulate you. And then I'm happy to join and continue to support all the work and then bringing people together. And thank you.
Thank you so much, Dr. Kim, for your final remarks. And that's a perfect way to round out our conference for the day. Let me share my screen. So as Dr. Kim stated, as we wrap up today's conference, we really want to take a minute to sincerely thank all of you, including our speakers and panelists, for sharing their time, expertise, and insights throughout the day. I would also like to say a special thank you to our ASL interpreters, C. Reed, Allison Steele, and Kelly Shanahorn, for making the time to be here and helping make this conference accessible. And a huge thank you to all of you joining us with your engagement, your energy, your questions in the chat, and your commitment to advancing health access and technology. We hope today sparks some new ideas and connections you'll carry forward in your work and communities. Before we close out, I also want to share a few quick items. You can get in touch with Marylanders Online by connecting with us through our website, through email, marylandersonline@umd.edu, through our tech helpline, And you can scan this QR code to visit us on our social media platforms, including LinkedIn. And we will also have our YouTube page linked to that link tree that you can access to see the recording of this conference. And I'll leave this here for a brief moment. And if you'd like to stick around to network or to ask any final questions, we'll keep the meeting open for a few minutes. If you aren't staying to chat, please look out for a follow-up email from Marylanders Online. And please complete our conference survey, which you can find on the slide or in the email that we'll send out. And on that note, thank you again to everyone who was a part of this conference, because it's people like you who make these events so special. Wishing you all a wonderful rest of your day and weekend. Thank you, everyone. Okay, so for those who are still on the call, just wanted to open it up in case you had final questions or you wanted to stick around to network or get any information or resources from us. We will be closing the webinar exactly at 4 o'clock. So I'll be on here for another 3 minutes or so.
I just want to say congrats, congrats, congrats. Well done. This is Dr. Blake.
Dr. Blake.
Just really great job, Nerys. Thanks for leading the way all the way through. Just an excellent, excellent showing.
Thank you so much, Dr. Blake. We really couldn't have done it without you and your support and your help with marketing the conference. So I really appreciate that. And for all of those who helped with spreading the word, we really appreciate it. All right, about 2 minutes left. I see about 20 attendees left, just in case. Awesome. Thank you so much, Edna. Thank you, Genesis.